Hi, everybody. Welcome to Dermpath session. We're doing vascular lesions today with my awesome dermatology residents, Dermpath fellows, and maybe some path residents here too. Running a little late today, but let's do our best. Case 1, who wants it?
So it looks like we have a shave here, and we can see a lot of blood under the epidermis right off the bat.
Yeah.
And so it makes me wonder if maybe these are blood vessels down there. Yeah, they're not like involving the epidermis like an angiokeratoma. They're kind of below it. And we can kind of see vessels that are a little bit different, deeper as well. So looking at these structures now, it makes me feel like they are vessels, the ones that are more superficial. You can see kind of blood throughout, but and then there's nuclei. They're like hobnail nuclei. So makes us think of the Targetoid hemosiderotic hemangioma or hobnail hemangioma.
Yeah, very good. Targetoid hemosiderotic hemangioma, aka hobnail hemangioma. So let's go back to low power for a second. I hesitate for fear that the whole slide website will crash here, but one thing I think we can tell from this very beautiful deep shave is that this is a circumscribed small lesion, right? It starts here and it ends here. That's really helpful in vascular things to have that context of like how big are they, what do they look like. I always want to know too, is it in an irradiated site? You know, that kind of stuff is just priceless. If you're a dermatologist watching this, please always take pictures if you're going to biopsy a vascular thing. If you're biopsying breast after radiation or any site after radiation, like the clinical appearance can be incredibly helpful in these because vascular lesions can be challenging and the differential can be between something totally benign and something very bad. So it's important for us to sort it out. We've got, like you nicely described, Drew, big dilated, or what you could call cavernous, if you like, dilated open channels at the top there. And I like that you brought up angiokeratoma as a differential because it has very similar vessels, but they are entrapped in the epidermis. They're technically really in the dermis, but the epidermis is wrapping down around them, and you can see very little like dermal collagen around them. So that's a good differential here. But we got dilated channels up here. And then below those, much more subtle, but you can see kind of hemorrhage here, we've got little kind of trickling, almost, I'm using air quotes, infiltrative, compressed channels. You could say slit-like, although I try to avoid that term because it's the buzzword for Kaposi sarcoma. But it's fair here because I think Kaposi is on the differential with what we're looking at here. So what we have are these little compressed, thin cleft-like channels that kind of look like they're trickling between collagen, and that gives it an infiltrative appearance. But here on this relatively large biopsy, we can see it kind of ends down here. It doesn't infiltrate deeply, okay? So the cavernous channels with smaller compressed channels underneath, and then we're going to see usually down here hemosiderin. You don't have to have every single feature, but it's really nice when you can find it to support the diagnosis. Hemosiderin right here, those golden refractile deposits, and some blood. And then up here, the hobnail and endothelial cells. Now let's talk about hobnailing for just a second. What does it even mean? So in the old times, you know, there were like boots that had hobnails. I think they would use those on certain types of other leather products. They're nails that have kind of a bulging, rounded head on the nail, not like the flat top nails that we have today. So when things had a hobnail in them, it would have this little bulging protuberance that would protrude out from the surface of the thing. You can Google it and see some pictures. So one of those old-timey words that is stuck around. The other way that I hear some people describe it is they look like the heads of matches. Also, I guess old-timey since you don't see matches as often anymore. But they basically are endothelial cells that kind of bulge and protrude into the lumen. Sometimes they look like they're almost like a round nucleus, like almost about to fall off and you know, drop off of the edge. You know, does that kind of make sense there? They're kind of pinched underneath. So whatever works for you, these kind of tall, bulging little endothelial cells that stick into the lumen. Classically, in the cavernous spaces of a hobnail hemangioma, you will see those cells. But hobnail cells can be seen in lots of things, and they do not by themselves make a diagnosis, okay? This entity typically has them, but if I had all the features here and didn't see perfect hobnail cells, guess what? I would still call this a hobnail hemangioma or targetoid hemosiderotic hemangioma, all right? And then other things can have hobnail cells. Angiosarcomas do. A lot of times, lots of other things. There's a type of hemangioendothelioma that does, Erythema hemangioendotheliomas. They do. So by itself, hobnail doesn't mean too much. Don't get worried about that. Don't fixate on that feature alone. I see people get real concerned about that. All right. What was the other thing? Yeah, those are all the features. The name sounds like Targetoid is the name, Targetoid hemosiderotic hemangioma, because sometimes they can have a target-like clinical appearance. But I would say that most of the time when I see these biopsied, the differential that the dermatologist gives me is rule out this plastic nevus, or sometimes they might have a vascular lesion on their differential. But I think the most common submitting differential that I see is for a pigmented lesion, that they look kind of like a brown lesion. I do not usually see them described clinically as targetoid, at least the ones that I've diagnosed. And I don't often see them having a red or hemorrhagic appearance, usually more of a brown appearance, probably because of that hemosiderin under them. So the differential here would be Kaposiform because it can have the trickling channels underneath. All right. If you just had these channels at the top and they bulged into the epidermis, you can think of Angiokeratoma. If you just had channels like this at the top and they were filled mostly with pink, frothy kind of serum or lymph material and not as much blood, you could think of lymphangioma or lymphatic malformation, can have a close overlap with this. And in fact, these lesions actually, if you do immunostains on them, are thought to actually be truly lymphatic. So some people have suggested that these actually may be true lymphangiomas because they actually do have a lymphatic phenotype in these dilated vessels. So it doesn't really matter, but in any case. And then the last and really important thing is if you see something like this, and it's on the breast of a woman who had a lumpectomy with radiation therapy, then the diagnosis is actually atypical vascular lesion, lymphatic type. Even though they don't really usually have much endothelial nuclear atypia, but they are these skin-colored, usually, papules that come up in radiated sites, and most of them do not progress to angiosarcoma if they have the lymphatic or the appearance that looks like this. But in any case, they are important to know about because they have some unique clinical considerations that must be taken into account. And I have a separate video on that, and I'll try to leave a link down below, or you can look it up on my Kiko Index or my YouTube channel. All right, we've already gotten behind because there was so much to cover here. But this is a very nice example of targetoid hemosiderotic hemangioma. In any case, this is a really good example of targetoid hemosiderotic. And if you have any doubt at all about could it be Kaposi, do HHV8. Most of the time I see these are in kids or young adults, the kind of time that unless someone has AIDS, they probably do not have Kaposi. But you could, never fault someone if they're thinking of Kaposi. HHV8 or LANA1 is the other name for that immunostain. It's such a great, it's as close to a perfect immunostain as you can get. I mean, no stain's perfect, but it works close to 100%. So in any case, it's an easy way to make a difference between, Kaposi versus something else. So if you have any doubt, you can do that stain. All right. Now we've got case number 2. Who would like to do this one?
I could do this one. So we have a very deep punch with this large sort of collection of purplish cells deep in the dermis, like abutting the fat, and then some involvement of like the more superficial dermis as well. So my first thought is like, oh, is this something bad? It looks really monotonous, dark, kind of funny looking. But when we get in here, it's very, very monotonous, and we're having some blood vessels here. And just looking at the cells, of course, like if they weren't sort of in these collections, I would think of something like the small blue cell differential with like, is this like a lymphoma or leukemia or something? But looking at these look more like glomus cells. So this would be good for like more of a glomus tumor, I think. I don't know that there are as many blood vessels to say like glomeangioma, but those always kind of like trip me up.
Well, it's, yes, very good. This is a glomus tumor, and whether it's glomus or glomeangioma, A, is usually not of any real significance clinically. There are some differences, like there is a familial form of multiple glomangiomas that's inherited, and that, my understanding, I don't know if I've ever actually seen a patient with it in real life, but my understanding is that is usually just glomangiomas, not solid glomus tumors. But in all honesty, the distinction between glomangioma and glomus tumor is a matter of like, it's very subjective, like how many vessels do you think there are? To me, if it looks like a solid nodule, I'd call it glomus tumor. Glomangiomas are also known as glomovenous malformations. They really look more like a kind of a vascular malformation, but with some rimming of glomus cells around the individual vessels rather than making a solid nodule. But again, it's the difference between those is really of no significance. So I wouldn't lose sleep over that. And you're right that in some cases of glomus, because they have round, dark little cells, And it may vary from case to case. This case looks darker. I think the stain, the H&E stain here may be a little dark. I'm trying to find an area. This slide seems to have been scanned out of focus a little bit. Like it was like maybe a little thick cover slip or something. So I can't quite get it to come into clear cytologic detail. But we have really nice, very monotonous, like you said, round little cells. They can be blue. Sometimes they look more pink. They can sometimes have more abundant cytoplasm. And so one key is, like you said, that you could think they're in kind of the fused sheets, but then when we look at the edges, they really are kind of clustered around vessels and making nodules in a growth pattern that we wouldn't usually see in other types of round blue cell tumors. But maybe you would certainly be forgiven for thinking, could this be an epithelial thing, like a sweat gland tumor? Could this be a spiroadenoma from low power? I mean, spiroadenoma would be a very reasonable differential here, multiple blue balls or nodules of cells in the dermis and subcutis. When they have more abundant cytoplasm that's pink or clear or pale, you can think of a hydroadenoma. So I think glomus tumor is a really important thing to keep on your differential with sweat gland neoplasms because it can look similar. These are actually modified smooth muscle cells or pericytes. So this is a true pericytic tumor. And they'll stain with actin, but they'll be negative for desmin, also negative for keratin. So if you were concerned about maybe it being an epithelial tumor like a sweat gland tumor, using a keratin would easily solve that problem. And they tend to, let me try and find a good area, they tend to kind of arrange themselves in kind of linear rows that often are multi-layered, and so they will wrap around vessels with multiple concentric rows. This one's not maybe the best example of that, but people call that onion skinning. We have that term onion skinning way too many times in pathology for my liking, but it is, I think, actually kind of apt for these usually, although, like I said, this one's not cooperating as well. But they tend to line up with each other, and they tend to be in multiple layers. So that's a nice example of glomus. The nail bed under the fingernails or toenails is probably the most common site, but they can really occur almost anywhere, usually in the skin. Occasionally you can have them in internal organs like the stomach, where they can actually be more problematic diagnostically because they can mimic like neuroendocrine tumors and things like that. So good example of a glomus tumor. And the vast majority of these are benign. There are rarely atypical and malignant forms. And there are some papers in the literature published about how to tell those apart. Normally, if you start seeing mitoses and pleomorphism, then you need to stop and go look up, how to tell malignant glomus tumor. And there's a good article. I'll try to put a link in the video description so you can check it out. All right, glomus tumor, very nice.
Okay, I'll take this one. So we're looking at either pretty big punch or maybe small excision. Right away you're seeing kind of these most likely vascular proliferations in the dermis because you can already see their extravasated reds and red blood cells that look like they're still in vessels. So thinking this is, vascular proliferation right off the bat, you could think of, I think, like a glomeruloid hemangioma, but I think those are supposed to be more like in crescent type shapes, and they're kind of like protruding into that, which you don't really see here. These look more like, well, there's some areas that look more like the cannonball tufts of vessels. So I think I would be, at this point, probably leaning more towards the tufted angioma.
Yeah, very good. This is either you can call it a tufted angioma or a Kaposiform Hemangioendothelioma. Those are two names for basically the same tumor or the same spectrum of tumors. People have debated over that a lot over the years. But really, when they're large lesions that are larger and more infiltrative and deeper, particularly in babies or having been present since infancy, we tend to use the term Kaposiform Hemangioendothelioma. When they're small lesions in the skin of adults, we tend to use the term tufted angioma. But honestly, when I sign these out, I usually put, Kaposiform Hemangioendothelioma / tufted angioma, with the comment that these, in the WHO soft tissue book at least, they are basically on a spectrum. And my mentor, Dr. Weiss, said that they look essentially identical microscopically. So the real difference in the naming there is that when they're large, and in babies particularly, they have a tendency to do this thing where they trap platelets in these little these little whorled nodules of spindle cells and compressed vascular channels. And that's called Kaposiform syndrome, and that can lead to thrombocytopenia. And in a subset of patients, that can be very serious and even potentially fatal in some cases. So, hemangioendothelioma is a complicated thing that we don't have time to delve deeply into, but basically it is a term for different types of vascular tumors that are not like fully benign and not fully malignant. But each one of those different types of hemangioendothelioma are totally unrelated to each other. They're not like morphologic variants of the same thing. They are all unique entities that get labeled hemangioendothelioma because they don't fit neatly into a benign or a malignant group. That's the simplest explanation I can give in a short time. So basically, don't think like, oh, there's just different flavors of hemangioendothelioma. No, each one is totally unique and separate. So some of them some types of hemangioendothelioma are called that because they can metastasize occasionally or be aggressive in other ways. This one basically never metastasizes, or almost never. I think it can involve regional nodes sometimes, but distant mets is basically not a problem with these, to my knowledge. The bigger problem is that when patients have a problem with these or die from these, it's because they have really large ones and they have thrombocytopenia that's uncontrollable. So they're more of an issue with outside of that setting. The issue is that if they're large, how do you manage them? Because you don't want to do like real extensive surgery if you don't have to, and sometimes they can be pretty big. So that's a much more complicated issue. Sometimes people have used different medications to try to manage these, and that's an area of growing interest. But diagnostically, how do we diagnose them? They're often either a plaque, a violaceous erythematous plaque, or a big nodule, depending. And they have two main features, these blue cannonball-like nodules, which compose of compressed, cleft or slit-like vascular channels and spindled cells. And then also in the background, dilated lymphatic channels. And these irregular, ectatic, kind of branchy lymphatic channels, you can even see, look, little valves in there. Isn't that cool? So these look similar. If you didn't tell me any history and you just showed me this, I'd say maybe this is from a person who has lymphedema, because this is the kind of vascular channel change you get in the setting of lymphatic stasis, like lymphedema. So you get these dilated lymphatic channels and then these nodules here, and they're usually kind of multifocal and kind of infiltrating throughout the dermis and into the subcutis. Sometimes you can have larger, more cellular ones, but most of the ones I've seen have looked like this. All right. If we look closer at the vascular channels here, they have, again, thin little compressed spaces, and the endothelial cells can be a bit spindly, and there's also going to be some spindled pericytes in between. And if you do a platelet stain, CD61, particularly in the big cases in babies that have Kaposiform, you can actually see little platelets getting trapped in the middle of these little spaces. So that's kind of the idea of how the platelet trapping happens, okay? And the idea is that the name Kaposiform comes from the fact that, this kind of slit-like spaces and spindle endothelial cells could vaguely resemble Kaposisarcoma. The growth pattern here is not, to me, very typical of Kaposisarcoma in most of the cases I've seen, but they can sometimes have areas that resemble Kaposi. But to me, this looks really nice for Kaposiform Hemangioendothelioma, aka Tufted angioma in this case.
Okay, I'll take this one. So at low power here, it already looks like a very busy dermis, and that's where our action is. We're getting some suggestion of crack-like spaces here and proliferation of vessels. Now we're starting to see some extravasated red blood cells.
Yeah.
Okay, and here it's starting to look more like we're getting those slit-like vessels almost dissecting between collagen in certain areas.
Very good.
And I think we're starting to see some atypical cells as well. Angiosarcoma.
Yeah, good. This is Angiosarcoma, and I think we could talk forever on Angiosarcoma because it's a very complicated topic. But like you said, it's a busy cellular dermis here. And when you go in, you begin to see little spaces between these tumor cells. And look, there's hobnailing. See the cells bulge into the lumen here? So that's like I told you, that can be seen in lots of different things, angiosarcoma and other malignant things and other benign things. So it's not a specific feature. But here, it's actually a little hard to tell, are these spaces actually vascular or not? And so in cases like this, immunostains can help. But you could also wonder, could this be melanoma or a carcinoma or something where the tumor cells are falling apart? Certainly here, look, I mean, it's like almost solid. There are some spaces, but I see artifactual spaces in poorly differentiated, epithelioid tumors in the skin all the time. So immunostains can be helpful. ERG and CD31 are my two favorites, but CD34 can also work as long as you remember that some angiosarcomas lose expression of CD34. The more helpful thing is if you're lucky and have a big enough biopsy, go look at the edge of the lesion. And then the vascular channel formation, usually, if you have a big enough sample, usually you'll begin to see more obvious areas of true vasoformation. In the center, in cellular zones, it can be quite challenging to recognize angiosarcoma, which is why I always keep it on my differential for poorly differentiated malignancies, either spindle or epithelioid cell in the skin of older sun-damaged adults particularly, or in radiated sites. But here we see dilated channels, and we've got bulging hobnailing of endothelial cells into the lumen. And then in other areas, you can see that the lumens start filling up with cells. That's kind of what's happening here. Sometimes on immunostains, it's easier to see. Like here, this probably used to be a lumen, and now it's full of multiple endothelial cells. Kind of like people have described it as fish in the creek. Like it's a bunch of fish swimming together in the middle of the river, the creek or stream that the vascular channel is. And so that filling up of lumens of vascular space is not good. The infiltration between collagen in general is a worrisome sign, although some benign things can trickle in between collagen, and particularly like Targetoid hemosiderotic hemangioma we talked about earlier, microvenular hemangioma. There are other benign things that can trickle between collagen, and which is why we often teach about those, because they're trickling, kind of pseudo-infiltrative growth can cause them to mimic angiosarcoma or Kaposiform, okay? So it's important to know about those. Here you can see more of the vascular channels, and again, the multiple endothelial cells filling the spaces. And this one is not as ugly as some. The endothelial cells here are kind of monotonous rather than pleomorphic, but they're quite big. They're quite large compared to normal endothelial cells, and it's way too cellular. And if we looked around and had a better scan, I'm sure we'd find mitoses here. And then you get filling in, see these pink bundles are collagen. And so this tumor is streaming between the collagen, and usually you will find this. You will find endothelial cells wrapping around individual collagen bundles. That is a worrisome sign. And angiosarcoma particularly likes to wrap individual collagen bundles. Kaposisarcoma can do that too. And then the last thing is, if we didn't have any information provided us clinically, and this was an exam, go and look at the periphery of the skin to try to give you some context clues about where you are and how old your patient might be. Here we've got large sebaceous glands and large hair follicles, so we're probably on the face of an adult. And we've got blue stuff, solar elastosis. So we're on the face, probably, of an old sun-damaged adult. So vascular spaces with hypercellular endothelial cells that are filling up the channels and infiltrating the collagen on the face of an old sun-damaged adult, that's angiosarcoma until proven otherwise. So that's what we can take that context, and that can help us a bunch, because it's extremely rare to see angiosarcoma in kids or even young adults. The main, setting what we might see angiosarcoma in a younger patient is if they've had radiation therapy. Or maybe there's some other very niche, nuanced circumstances. But usually when I see angiosarcoma, it's in the skin on the sun-damaged older adults on the head and neck usually, or in the setting of radiation, or sometimes in chronic lymphedema. The vast majority of angiosarcoma cases I see are in those contexts right there. All right? And that's another area where you can see the cellularity and the filling of vascular spaces. I have many videos and digital slides and resources about angiosarcoma online. It's a very, very serious disease with aggressive behavior in many cases. It's important to be very careful when making this diagnosis, and don't give it lightly, but also try not to miss it, because it's very serious either way. And you're buying someone a huge surgery and a really serious prognosis. There's really good example of infiltration and entrapment of individual collagen bundles here with endothelial lined spaces in between. All right. Case 5.
I think we're back to me. So we can see like a very well demarcated globule here in the dermis, and there's a lot of like lumens within it. Even looks a little like myxoidy in some areas, or like kind of mucinous change in some areas. But yeah, and also looks like kind of like smooth muscle type cells throughout it.
Yeah.
And so you can think of Angioleiomyoma,
Perfect.
which I remember you were saying, like, a lot of times can have multiple lumens, which I think when I was first learning it, I feel like I always saw pictures with just like one vascular lumen in the middle.
Yeah, very good. Yeah, the circumscribed nodule, usually in the subcutis. The kind of classic location is the lower leg of an adult woman, and it's a painful nodule, but they can occur at other sites, and so it's not always in women. But that is a kind of classic test exam question. Here, look, you can see one vessel out here, like one at the edge. So sometimes you get one big muscular vein. These essentially always are arising from the muscular wall of veins, not arteries. For some reason, leiomyomas like to arise from venous smooth muscle, not arterial. I don't know why that is. But in any case, sometimes you'll see a large muscular vein at the edge, and then the nodules coming off the edge of that. Or other times you can see it kind of trapped in the middle like a giant donut, which makes me hungry. But much more often we see this pattern, at least in my experience. Multiple lumens of varying size, and each lumen you can see is kind of wrapped by the muscle that kind of spirals out into the background. So the muscle here has the cytologic features of smooth muscle like you'd see elsewhere, with kind of the cigar-shaped nuclei and abundant eosinophilic fibrillary cytoplasm, and sometimes little glycogen vacuoles next to the nuclei. I'm having a hard time getting it to come into focus. This is kind of a funny scan, but here little glycogen vacuoles, here these little clear bubbles. But the muscle does not make as well formed of fascicles as you'd see in, say, a pilar leiomyoma in the dermis, right? In those you can see nice fascicles intersecting at angles, and here you get a little sense of fascicles, but much of it, the muscle is swirling around each of these vessels and then merging into the neighboring vessel with its muscular swirl. And so because of that, you don't really get the good fascicle appearance that we see traditionally in leiomyomas, like in the uterus or the dermis or other places in the body. So recognizing this is just from the multiple lumens, the pink muscle swirling around it. And sometimes you can get some fat caught in the middle of these, and that's totally fine. It doesn't change the name or the diagnosis. And what was the last thing I was going to tell you? Oh yeah, if you see something that looks kind of like this, but is a little bit more blue because it's more cellular and has less eosinophilic cytoplasm, and is a little more like swirly spindle cells swirling around multiple vessel lumens and a nice circumscribed nodule, that would be called a myopericytoma. I feel like it's a worthwhile thing to learn, even though it's probably not really related to angioleiomyoma. It's more molecularly related to myofibromas, actually, is the current thinking. But I feel like, to me, morphologically, it kind of reminds me a bit of an angioleiomyoma, but a little bit more cellular, more spindly, thinner spindle cells, more swirly and whirly. I've got an example of one of those on my Kiko mega index for soft tissue, so you can go search that page if you want. I'll put a link down below. And it's for comparison. But I think it's a worthwhile tumor to learn while you're thinking about angioleiomyoma, because it has, to my mind, some morphologic overlap, even though it's not related. And this big space here is just an artifact. This is just the tissue is retracted during processing. It's not actually a true vascular lumen or anything in this case.
Okay, so again, we're looking at another dermal process. I don't know if this was cut a little tangentially. The epidermis looks a little bit funny. But then we kind of have this sort of almost pedunculated papule. I would expect it to look like clinically. Lots of blood so far that you can see. Just very busy looking.
And what about this on the side? What do we call this structure here?
A collarette.
Very good, yes.
And then looking in here, I thought that the sort of like fascicles of cells were moving through, and there's sort of blood cutting in between them. It's hard for me to describe it well, but I feel like this looks good for Kaposi's, just how the blood and the cells are sort of traveling together.
You described it perfectly. I like that description.
Thanks, Dr. Gardner.
Yeah, this is Kaposi. Very good. And you know, Kaposi comes in a few different kind of clinical appearances. There's a few different clinical scenarios and settings that Kaposi comes in, right? The kind of classic type, which is in the lower extremities of older adults. People had traditionally said it's more common in Ashkenazi Jews or people of Mediterranean descent, but I have seen Kaposi in folks of all different ethnicities and backgrounds. Older adults get lower immunity, and the HHV8 virus, which is pretty common, can take over and cause Kaposi's sarcoma on the lower extremities particularly. Then we see it in the setting of AIDS. There's the endemic form that happens in Africa, aside from HIV, non-HIV associated, which I've never actually seen a case of that in real life just because of my practice setting. And then there's also the iatrogenic form in people that are immune suppressed, which you would think would be more common, but I have to say I've seen a lot of immunosuppressed patients over the years, and I think I've only seen one case where I think it was probably from the immunosuppression. So I don't know, but I think that must be actually relatively uncommon, because considering the number of other immune suppression associated things I've seen in practice, I've only, I think, seen one immunosuppression Kaposi sarcoma. Most of the cases I've seen have been in elderly adults, the classic form of Kaposi. And then, so those are the different like types of Kaposi from their scenarios. Then there's also three kind of different stages, if you will, or presentations. There's the patch form, there's the plaque form, which looks like a plaque, and then there's the nodular stage of Kaposi, or kind of tumoral stage, if you like to think of it that way. And that's what we're looking at here, the nodular form of Kaposi. I have no way to tell what type of setting, if this is arising in a classic form in an elderly adult on the lower leg, or if this is because of HIV. I have no way to tell microscopically which one we're dealing with. But I can tell that it's probably the nodular presentation because it's a nodule, right? So I think it's important, much more important for pathologists, is to recognize the different patch, plaque, and nodule stages of Kaposi, because that changes how they look microscopically and clinically. All right. The nodular form tends to be a nodule like this. It can present with a collarette, which can make it look a little bit like a pyogenic granuloma, both clinically and microscopically at first glance. And I've seen cases that actually had PG-like changes or nodules of granulation tissue right next to an ulcerated nodule of Kaposi, which can create even more confusion. So when you see a spindly lesion with a lot of blood, right away think of Kaposi, all right? The one problem that does come up sometimes with nodular stage of Kaposi is that I've seen some cases where the blood is relatively minimal or even lacking. And in those cases, it can be very difficult to recognize that you're looking at Kaposi, because we focus so much on the blood-filled slit-like spaces between these plump spindle cells that are running in fascicles. It's like the classic appearance. And in nodular stage Kaposi, it is usually present. So it's such a great diagnostic clue, but every once in a while, this is lacking, and what you get is a cellular nodule that's got fascicles without blood, and you may scratch your head for a minute and be like, what on earth are we dealing with here? And so, like, for example, here, there's fascicles of spindle cells. They don't look, this is a poor quality H&E and scan, so we're kind of doubly hindered here. But they are kind of plump. They'll have mitoses, but usually they're not wildly pleomorphic. If you see a vascular tumor, even one that has slit-like spaces and blood, but looks super pleomorphic and ugly, you should think of spindled angiosarcoma before Kaposi. If you see something that looks like Kaposi sarcoma, but it's on the head and neck of an older sun damage patient, that to me is angiosarcoma until proven otherwise. I don't care how much it looks like Kaposi, unless you prove it to me with the positive HHV8 in that context clinically, it is so much more likely to be Angiosarc than Kaposi. So clinical context matters a lot. But we've got the cells tend to be plump and they have mitoses, but they're not usually very pleomorphic. There are some exceptions, particularly like in people with AIDS. There is a pleomorphic form of Kaposi. So if there's any doubt, do an HHV8, because even though Kaposi sarcoma and angiosarcoma, you might think, well, they're both vascular and they're both called sarcoma, so they're pretty similar, right? Nothing could be further from the truth. They are a night and day difference as far as treatment and prognosis go. I have a long video I did with my friend Josette McMichael, aka Global Dermy, on Instagram, and you can check that out on Kiko or my YouTube channel. And she goes through the clinical features of Kaposi, and I go through the path features. And it was really fun working with her because she and I know each other IRL before social media, because she was a senior resident at Emory in dermatology when I was doing my Dermpath fellowship. And she's just a lovely person and an amazing, brilliant dermatologist. And it was such an honor to collaborate with her. So anyway, plump spindle cells, mitoses. What was the other point I was going to tell you? Oh yeah, Mark Edgar, my one of my soft tissue pathology mentors, taught me a really cool thing. We always focus on the fascicles with the slit-like spaces, right? Like you can see over here, like Grace nicely described, with the blood kind of tracking along in the spaces in the same direction as the spindle cells. I love that. But what happens if you cut a fascicle in cross-section as opposed to longitudinal? Well, all of a sudden, the cells don't look spindled anymore. They look more round. And what happens to those slit-like spaces? They don't look slit-like anymore. They also look round. So this right here, what we're seeing is a fascicle cut in cross-section as opposed to longitudinal. And Mark Edgar said this is a sieve-like pattern. instead of blood-filled slit-like spaces, it's like little round circles, like a spaghetti strainer, a sieve, a colander, whatever word you want to use for that, a pasta strainer that, you know, has multiple little holes in the bottom, each of those holes filled with erythrocytes. So I love that because sometimes you won't see the good cut to get the fascicles. Here's a fascicle, and then here is the cross surface, the cut surface cut the other way, 90 degrees to the fascicle. So you can see them back to back here. Slit-like spaces, sieve-like spaces. Both of them are a great clue for Kaposi sarcoma. Usually you will see plasma cells around, and you can use HHV8 to support the diagnosis if you need to. I often do it because it's easily available in my lab, and it's such an important thing to get right, and it's such an easy single immunostain that solves the problem. All right. And you may or may not see patches or plaques in the background of the nodule. I would say more often when I see nodular Kaposi, if I go look next to it, I don't usually see patch or plaque stage next to it. I usually see a single nodule like this existing by itself more often than not. So that can also kind of cause confusion if you're, you know, not expecting that. All right, very good. Oh yeah, the last thing. Kaposi is more a disease that we treat kind of managing symptoms or palliatively. You don't like really cure it unless if you get someone's HIV under control or you find a way to reverse their immune suppression. But it's not a thing that we go and do wide local excision surgery on. You may remove some nodules of it for palliation or do various other treatments for palliation, but it is really a disease that is not cured in the traditional sense because it's virally driven. So it can be multifocal, not because it's metastasized, but because the virus is involving multiple areas of the skin. And also it doesn't usually metastasize. There are forms that can be more progressive and get into the organs and stuff. But most often when I see this, it's a disease that people die with rather than die from, if that makes sense. So again, it's very, very different from Angiosarcoma, which is managed totally differently from that. So really important to understand that and to make that distinction between the two.
Okay, so I think I'm up. Here we have a shave of a, looks like a small papule. Even from low power, you can see that there's like these, you know, spaces with proliferation within those spaces. I think this is really good to contrast with tufted angioma I had before, because, you know, we're really seeing what I think are vessels, because I can see red blood cells kind of collected in them. And you could sort of say that these spaces are somewhat crescenteric.
Yeah, like look there, right? Crescentic, we've got a dilated space and then a little tufted tangle of capillaries pushing into that, right? Same thing right here. Right there, right there. I mean, those really do look like what?
Glomeruli.
Glomeruli. I mean, they really are, I mean, very reminiscent of glomeruli. This is a great example. This is like better than the book. So, like I told you earlier, I think that sometimes they can have some overlap, but I think this one's a pretty convincing example that it's not quite as spindled and slit-like as the nodules in tufted angioma, Kaposiform Hemangioendothelioma. These are more like open little lumens tangled up in a coil together, bulging into a dilated pre-existing space. So this is what?
Would be a glomeruloid hemangioma.
Yeah, this is glomeruloid hemangioma, and these are usually associated with Poems syndrome, right? So pretty cool. I was just telling you guys that I've rarely seen one. I think this is better than any example I've seen in a study set or anything. That's fantastic. Right, 8.
Okay, so we've got a punch here, and again, it looks like the action's in the dermis. So it's starting to look a little kind of patchy throughout the dermis, and when I see that at this power, I start thinking that this is maybe a vasculocentric process.
Yeah.
And you can see vessels kind of scattered throughout these areas. And here now we're starting to get more of a suggestion of some fibrosis around the vessel.
Yeah, very good.
And it does look like we've got some fibrin, maybe some karyorrhexis, so like a vasculitic type process. And then with the onion skinning fibrosis, we need to know location on this one, but I didn't see like adnexal structures, just face. So favoring we're probably somewhere else, maybe leg. So this could be Erythema, elevatum, diutinum.
Very nice. Yes. So this is EED, and I think you're right that we do have to take the context into account here. From low power, my first thought was really severe vascular stasis, like acroangiodermatitis, because that's like a million times more common than EED. And bad stasis can sometimes look like this, where you get like lobules or little nodules, multifocal in the papillary dermis with a lot of sclerotic, scarring, fibrotic background, right? But when we look closer here, what we see is that the vessels here, even though the vessels look a little bit like stasis vessels, they've got a lot of neutrophils around them, and they have some nuclear dust and some fibrin. So it seems like there really is vasculitic change here. And then in addition to that, there is a lot of kind of swirled onion skin fibrosis or scarring around each of these nodules of vasculitic small blood vessels. And eventually, over time, as that scarring and vasculitis progresses, it forms kind of enlarged, thickened plaques or nodules. I've only seen erythema elevatum diutinum a few times, but as you guys know, it is a form of fibrosing vasculitis. It has some overlapping features with granuloma faciale, although this tends to have more vasculitis and more fibrosis and kind of less dense sheet-like inflammation. And clinically, they seem to be a bit different too, but there are sometimes you can have overlap and have cases that have a little bit of features of one or the other in them. So it does have to be made in the context to make that it makes sense clinically. Yeah, this is something I've only seen or suggested just a few times in my, a decade of practice. Really, really uncommon. And I've seen one case clinically when I was in fellowship. They had like an educational seminar where patients with rare diseases came in so that everyone could examine them and learn from them. And one of the patients had EED. So I got the really rare opportunity to see this up close. In real life, the other thing to think of if you see this is the fact that stasis can sometimes get a little bit of vasculitis around it, particularly if it's ulcerated. So in ulcerated lower leg, severe stasis is not super surprising to see a little bit of vascular damage and neutrophils around vessels. So that's why we do have to, make sure that it makes sense clinically to be EED. And I have a couple videos about vasculitis that kind of delve more deeply into that, and including one which shows a more robust, well-developed nodular example of EED. So you can go check that out. I'll put a link down below, or you can check on my Kiko index. Sometimes I forget to go back and put the links. Oh yeah, here's the fibrin. So you can see, and I wanted to bring this up because this is a good contrast. People often struggle with what's the pink smudgy stuff in pathology. There's lots of things that are just pink, hypocellular, and telling them apart sometimes is really important, but it's challenging to do. But here is the fibrin up here around this damaged vessel with neutrophils embedded in it. It's brighter red, it's more smudgy, and then this is collagen here, the collagen of the fibrosis. And you can see individual little strands, little tiny threads of collagen, and the texture is different. I know it's a subtlety. The color's a little different, fibrin, and then down here, collagen. And you can use things like trichrome to kind of help you sort that out if you're struggling. With practice, you can do this on H&E. But if you struggle with the pink smudgy stuff, it is hard. And multiple people have asked me to make videos about that. And I've drugged my feet because I know it's hard and I'm struggling to find the best ways to explain it to people. But I'm going to try to put that on my to-do list. Case 9.
Right, here we can see there's a papule. It looks like the epidermis ripped off or picked off or something. It's absent. And then there's like an epidermal collarette on the sides. And in the middle, it looks like kind of reminiscent of granulation tissue, like lots of little vascular proliferation here. But not like great like lobules or anything, but still looks good with the pale stroma and all that stuff. It looks good for like the pyogenic granuloma.
Yeah, very good. This is pyogenic granuloma, also known as lobular capillary hemangioma. Papule that's bulging up from the skin, often ulcerated with neutrophils over top, thus the name pyogenic, but you don't have to have that. So pyogenic granuloma is kind of like the ultimate misnomer because there's not always pyogenic, and it's definitely not a granuloma, but as we know in dermatology, old-timey names tend to stick around forever. So the appearance can be quite similar to granulation tissue, and sometimes it's hard for me to tell apart, is this polypoid granulation tissue or a true pyogenic granuloma. Kind of depends on the context, and it also probably doesn't always matter. But sometimes PGs can be important because even though they're benign, they can be recurrent, and so you know a lot of times people will remove them and cauterize them or do various other things to try to keep them from growing back. Because they're ulcerated, you will see in large endothelial cells, you can see mitoses, you will see large plump myofibroblasts in the background, you can see vascular damage and neutrophils and sometimes nuclear dust that looks a little like vasculitis. Most of that is just secondary to the ulcer and the surface inflammation. So this is a disease that's important. Really see it at low power and get the idea. Then you can look closer. But if you go straight to high power, you're going to freak yourself out because you're going to see some mites and some mitoses and some big endothelial cells, and you're going to start getting scared. And often these are in kids or young adults on the lip or the finger, but they can be other sites too. And you know, here we do actually get a little bit of lobularity down at the bottom. See, here we got a lobule. We've got a lobule. Here's a lobule. Here's a nice lobule. And the lobules are cellular capillaries that are packed together in these little cellular lobules. And sometimes also as the PGs start to regress or involute on their own, the lobules can kind of start going away, and the spaces that used to have a lot of capillaries get replaced with fibrosis. So you can kind of have involutional change, which is like kind of more scarring and fibrosis, replacing the nodule of vessels in the pyogenic granuloma, lobular capillary hemangioma. So very nice example here. And the collarette is a pretty classic finding that's usually present. There's a collarette, kind of the sweat ducts coming down from the epidermis and scooping underneath the nodule on both sides. And there's a variety of other diseases in Dermpath that can have that as well. So it's a good clue to learn to help you narrow down your differential when you're starting out at Dermpath.
All right, so looking at this, we have a large specimen, and then deep down in the dermis, we have this, what looks like a pretty big clot, or at least what was a clot. Lots of blood, fibrin in there. Looks junky.
Yep. So it looks like clot there, even though it's not totally in focus. I think there's fibrin and some cells mixed in and some blood. But then what's happening over here?
It looks like it's trying to recannulize. So trying to open this blood vessel back up or kind of make its own little wall over here. So this would be good for IPEH or Masson's tumor.
Yeah, this is a really good example of so-called Masson's tumor with air quotes around it, because it's not really a neoplasm at all. It is just like you said, it's a thrombus that is recanalizing. So it is a pattern of organizing thrombus. When a thrombus forms in a vessel or in any setting, it's got basically three options. It either dissolves and undergoes thrombolysis, or number two, it totally scars down and blocks off the vascular space, and then the blood has to find a new path around it. Or number three, it recanalizes and makes new lumens through the middle of it. And sometimes the pattern of endothelial cells digging new lumens through that thrombus creates this unique, very busy papillary look. And so this is called intravascular papillary endothelial hyperplasia, IPEH, like you said, or Masson's tumor, in honor of Dr. Pierre Masson, who described this in the late 1800s, I believe. And my understanding is that in his original paper, which I think is in French and I have not read, is that this was mentioned as being something that can resemble angiosarcoma, but is present inside a pre-existing vascular space. And I think that's very apt and important description to remember, because otherwise you're going to find areas in this that look very complex, very ramifying, anastomosing, interconnecting channels, the kinds of vascular channel growth that we see typically in angiosarcoma, but that we can sometimes see in benign things also. But it's the thing that makes people worried. It's cellular, it's busy, it's not well organized and lobulated, and it's got all these channels. But if we go way back to low power, it's sitting inside a big, huge, dilated, cavernous vascular space. You can see more of it here, more of it here. It can exist inside like kind of an aneurysmally dilated vessel, a venous leg, the dilated vessels inside hemorrhoids. I most often see it inside of benign vascular malformations or cavernous hemangiomas, which probably are actually a type of venous malformation. It can be hard, especially if you get a deeper one where they've done a needle biopsy, or you just get a partial sample and you only see this stuff and you can't see that you're inside a vessel. But with practice, even in that setting, you can be pretty sure that this is what you're dealing with. And one of the best things is, just like you said, find the clot. find the area of definite fibrin thrombus, like right here, and unfortunately it's a little out of focus, and then you can see the thrombus beginning to kind of clump together. This stuff is pink, smudgy, and it's got blood. This is fibrin. And you can see the cells here, most of which are endothelial cells, but also some various, inflammatory cells, macrophages, histiocytes, whatever, lymphocytes. And you can see that they're beginning to grab this and to pull it apart into little small clusters and nodules, little pieces, which are then wrapped by endothelial cells. So finding that transition from a solid sheet-like area of fibrin thrombus and watching as the endothelial cells kind of dive and dig in between the fibrin and then carve out these channels, leaving behind these little papillae, which eventually over time seem to scar down and collagenize and become not real fibrin anymore, but more like actual collagenized fibrous tissue. That's what's happening here, okay? So if you had this same kind of pattern of growth into the normal dermis, wrapping around normal pre-existing dermal collagen, that would be very worrisome for like angiosarcoma. But here, when this is happening in a vascular channel and is recanalizing thrombus, then this is totally benign. So the context is important. Also, these are bland, benign appearing endothelial cells. They don't usually have much atypia, but it sometimes can be a little challenging to evaluate endothelial atypia when you're first starting out until you have a lot of practice looking at vascular things. So finding the pre-existing vascular channel on the outside is really helpful and important to solving this problem. But this is a nice example, even though I can't quite get it in good focus. Nice example of intravascular papillary endothelial hyperplasia. When I sign this out in my diagnosis line, I usually, like on a case like this, I would say like a benign vascular, I would probably say a benign vascular malformation, or we could say, large dilated vessel with organizing thrombus. I usually don't actually put Masson tumor or intravascular papillary endothelial hyperplasia in the diagnosis line because it sounds very complicated and scary. It's just a very busy, scary, complicated sounding name to a very bland actual process that is just a clot that's organizing. So to avoid, especially if it's a treating physician who may not be familiar with this terminology, I don't want someone to think it's some weird kind of tumor that they have to worry about. I want to let them know this is a benign process that doesn't really need anything further unless it's a mass that's causing an annoyance or a problem for the patient. So that's the way I handle it in my practice.
All right, so another shave. This one, we can kind of think of when we were talking on the first slide about the Targetoid hemosiderotic hemangioma, how that one was different because it didn't have these long areas in the epidermis kind of surrounding the vessels, which is what we see here. So whenever I see these, I think of like Sevi hemangiomas. So I think Angiokeratoma is good for this one.
Yeah, very nice. This is a beautiful Angiokeratoma. And like you said, the channels themselves look quite similar to those dilated cavernous channels that we see at the top of a Targetoid hemosiderotic hemangioma. The main difference here is that we're actually getting the channels get trapped up and wrapped by the rete of the epidermis. The epidermis reaches down and wraps around each channel, which makes it look like, this case doesn't show, perfect, complete wrapping of each vessel, but it doesn't have to be perfect wrapping of the vessel. But you get like what looks like a vessel floating in the middle of the epidermis. It's kind of an illusion because look, you can still see there's a little layer of collagen right here between the endothelial cell and the epidermal keratinocytes, because vessels can't just like exist totally naked in the epidermis, right? I mean, they have to have a connection to the dermis, and they're going to be surrounded by basement membrane. So in any case, that's what you've got. These vessels that are floating. It looks like they're floating the epidermis because the epidermis is wrapping around them. Oftentimes you get thrombus in here, and look, this thrombus is starting to organize and make some papillary endothelial hyperplasia, Masson tumor type of effect. There was a little more of it up in this top piece, actually. Yeah, look, blood and fibrin, and it's starting to get recanalized and starting to begin to make some little tiny tufts of papillae. Oh yeah, there you can see it even better over here. So see, this process is always happening. It's just not as florid as that last case. So learning to see it when it's doing this at a subtle level, you can begin to get really comfortable recognizing it. But this is nice, bright reddish pink fibrin, and it's wrapping into little tiny papillae here. So here I would call this a angiokeratoma with focal organizing thrombus. These also oftentimes break open on the skin and bleed to the surface. They often, I feel, get traumatized and have hemorrhage and ulceration on top. Totally normal. The biggest difference also between this and targetoid hemosiderotic is one, that the vessels get actually entrapped in the epidermis, and two, in targetoid hemosiderotic, you'll also, if you have a deep enough shave, see those little thin slit-like channels that are compressed and trickling between the collagen down below, whereas in true angiokeratoma, you just see these big cavernous spaces up top without those down below. Doesn't really matter either way, we're dealing with a benign lesion, right? I mean, I guess the one time it might matter is in patients with what syndrome? Do patients get multiple angiokeratomas?
Fabry?
Yeah, Fabry's disease, good. But, you know, most of the time when I see these are solitary incidental lesions, and they're biopsying them just to make, either because they're annoying the patient and bleeding, or because they want to make sure it's not a melanoma, because they often look really dark-colored, violaceous to black because of all the blood and the thrombus that begins to form in them sometimes. So, angiokeratoma. Oh, and again, if you have something that looks like this and it's a radiated site, then the answer probably is actually atypical vascular lesion, post-radiation atypical vascular lesion. So the context really matters. So if I see anything that has channels like this and it's on the breast of an adult, I want to check and find out, do they have a history of radiation? Because a lot of times you're not told that information. Sometimes the dermatologist may not even know for sure. So if I have access to the chart, I usually will go and look just to make sure there's not a radiation history. All right, case 12.
Okay, dermal process. Looks like a papule here and has a suggestion of a collarette on one side. But within the dermis, we have a more cellular nodule here that has scattered vessels. We're already starting to get a little bit of a suggestion of some hobnailing.
Yeah, and something like that channel there, we got some hobnails. But here, it's hard to tell, like, it's like a solid nodule, it looks like at first glance, right?
Mm-hmm. Yeah, and then starting to look at the cell types here, too. So there are definitely red cells, but there are EOs scattered.
Yeah, good. It's hard on this scan to see, but lots of red cells, but also lots of EOs. Anytime there's a bunch of red cells, it makes it harder to look for eosinophils, I think, because they have a similar color from low power. Up close, they look different. You can see red cells are homogeneous kind of texture, and EOs, even on this poor quality scan, they have granules, right? So, but from low power, it makes it hard to spot them because you keep thinking, oh, is it an eosinophil? No, it's just a red cell. So at least, I don't know if you guys struggle with it, but I do. And I've been doing this for a while. So, and look, what looked like a solid nodule, this is a trick. If we did a vascular stain here, you'd see there's actually lots of little channels, but the endothelial cells are so plump that they kind of squish and fill up the channel and make it hard to see the lumen. You can see here, though, where some of them are opening up, and there's actually a vascular channel lined by very plump, almost epithelioid-looking cells. So what do you think this is, then?
Yeah, ALHE.
Yeah, angiolymphoid hyperplasia with eosinophilia, or ALHE, or the other name for it is epithelioid hemangioma because of the epithelioid nature of the cells. And this may be there may be several different things that get lumped under this term. The WHO soft tissue book has recommended to not use the term ALHE, but because I do Dermpath, I still use it. And I put epithelioid hemangioma with ALHE parentheses or vice versa. But there probably are some things in the skin that get labeled ALHE that are actually like reactive processes, like a bug bite with exuberant vessel proliferation or other things like that. But then there are some that are probably true neoplasms. In the soft tissue or deeper down, I think most of the things are actually neoplastic, which is why in soft tissue they tend to call them epithelioid hemangioma. But I like that name because they do have really epithelioid cells. They tend to have lobules like this. Sometimes the vascular channels look completely like closed off by the cells so much to the point that they can look like nests of epithelioid cells. But again, with immunostains, what looks like a solid busy nodule here is actually quite well, if you do like a CD31 and maybe an actin here, you'll see that there's actual well-formed channels, and then there's pericytes and myofibroblasts in the background surrounding those, and you can see there's much more organization to what looks like kind of solid cellular madness here. And then finding the lymphocytes and the eosinophils is really helpful. They can be a varying amount. Some cases have like lymphoid aggregates with germinal centers, can look almost like lymph node cellularity of lymphocytes. And then sometimes the eosinophils are numerous like here, sometimes they are very rare and sparse. So it varies from case to case. Some cases occur in the skin. It can have a polypoid arrangement with a collarette that looks kind of like a PG, lobular capillary hemangioma at first glance. Other cases are going to be deeper down, like a classic site is on the temple or near there, often arising out of the wall of a damaged vessel, particularly the temporal artery, sometimes coming up after trauma. And so you can have one or multiple nodules, often in close proximity to each other. You can see them growing out of the wall of a damaged artery if you get a deep enough biopsy, in some cases at least, and even into the lumen of the vessel, which is totally not worrisome. These are benign, but they can be problematic because they do have a tendency to recur. And I've had multiple times where I've seen cases where the patient has had to have a couple surgeries because it kept coming back. I've had people contact me, surgeons from other parts of the world, asking because they saw one of my videos on YouTube and they're like, do you have any ideas for treatment of this? Because we have a problem with a patient with recurrence. And so there have been multiple therapies tried. And if you're one of those people watching this video, no, I don't know other than what I've seen in the literature. I think people have tried lasers and various, antihypertensive agents and stuff like that. And I'm not an expert on those things. But the problem is anytime there's multiple therapies, it's because none of them are particularly good at working all the time, right? So it is benign, but it can be locally problematic for patients, particularly if it's on the forehead or I've seen them in the ear canal a couple of times. And this can be more of an issue for people. And some of them are positive for FOS or FOSB, which you can do immunohistochemistry for or molecular testing for. And so that's I think about 50% or so are positive for one of those markers. So that's a newer marker that's come out in recent years to help us to identify these. And I don't have much personal experience with that yet.
All right, so we can see a lot of blood under the epidermis, really thin, atrophic epidermis. But yeah, lots of blood. And it's not collected in any sort of vessel or anything like that. It just looks like a big bruise, like solar purpura.
Yeah, very good. This is solar purpura. In the past, it was called senile purpura, but we try to avoid calling anything senile now because it's not very polite towards patients. Or Bateman's purpura is another name people have used for it. These are those bruises, the violaceous patches that you see often on the dorsal forearm of elderly adults with bad sun damage and really thin skin, and sometimes also exacerbated on people who are on aspirin or other antiplatelet drugs, right? So the problem is that sometimes we see blood in the skin and it's procedural, right? It happened at the time of the biopsy and it just spilled on the tissue. And so one clue to helping me know how do I know this blood is real? I know it's real blood, but how do I know it was really there in vivo rather than ex vivo that's occurred after the biopsy? Is I look at the clinical history. Was it a violaceous area that the dermatologist thought looked red or purple? So that can be helpful. And yeah, like you said, it just fills in and kind of layers in between the solar elastosis. Here at the side, we can see that there's lots of elastosis. And there's a very thin atrophic epidermis, and this is what happens in really severe chronic sun damage in elderly adults. Sometimes you can get some kind of cystic areas that look like they're lined by endothelium that look kind of like a vascular or pseudovascular space. Occasionally that will happen. Also, sometimes you can get some inflammation in these, which can make people think about vasculitis. That's been described in the literature in the past, that there's an inflammatory variant of this, which can really be confusing if you don't know that exists. Because it can mimic vasculitis. So just a couple clues there that you might want to know about. But normally, someone might biopsy this because they want to make sure that it's not an angiosarcoma. Clinically, they see a spreading violaceous patch that won't get better, and they biopsy it, and we say, nope, there's no vascular proliferation here. It's just all blood. But also, this can be seen incidentally adjacent to a wide variety of other things. So just because you find this, don't stop looking. Look at the rest of the biopsy and make sure it's not a 2-for-1, special, that you just have incidental solar purpura in addition to their, melanoma in situ or something. Okay, that's not what's happening here. This is just solar purpura. Okay, very nice. Good example, and it's not always this robust with the blood. This is a real extreme, a nice demonstration of it. Okay. Guys, I think it's time for you to go to clinic. I will carry on and record the rest of these. And then once I get them edited, you can watch it online later. I'll send you guys the link once it's done, or try to remember to do that. Hopefully it'll be before you graduate. All right. Thank you for your patience, and I hope you have a great weekend.
Thank you.
Thank you.
Case 14. As usual, I've gone overtime, so I've sent my awesome derm residents off to clinic, and my awesome Dermpath fellows, Dr. Michelle Pitch and Dr. Josiah Hansen, are now being called out by me, but they're going to stick around and power through the rest. All right, do you guys want to give it a shot? So let's see, what's this one? 14.
Sure. So looks like we're on the head and neck somewhere. We have this decently circumscribed purple nodule. Looks like there's some clear cell changes, and then in the other cut there are some more dilated spaces that had some vascularity to it. So kind of purple nodule in the deeper dermis subcutis with some clear cell change. Immediately you think of hidradenoma, but of course there's a differential there. Looking for ducts as it's loading.
Yeah, I know. My goodness. All right, let's see. Let's go look for ducts. So sometimes the problem here is you see spaces, and the question is, are they real ducts? Are they non-specific, artifactual spaces, or are they vessels trapped up in the middle of it? I think all of that can be kind of challenging. Like right there, like, I don't know. I kind of think that might be a vessel with endothelium around the edge. I can't tell because it looks like it's got I can't really tell. That could be, I could go either way on that actually.
Got some ductal stuff in it.
Yeah, it does. Like
secretion.
So it may be a real, like there, that definitely there's a epithelial lining. That I think is a duct right there. But you're right, probably that's a duct, but occasionally you can be tricked by, or I can be tricked by vessels that get trapped in the middle. Here's a duct. Sometimes the ducts will actually have like a more cuboidal looking or columnar looking lining around them. And oftentimes in hydradenomas, the ducts become very dilated, and that's where we get the nodular and cystic hydradenoma. The cyst spaces are actually ducts that are just massively dilated. Like we're starting to see that here, and we've got some dried sweat secretion or inspissated sweat secretion in the lumens here of these. And there, look, see it is like a more cuboidal cell that looks a little different from the rest of the cells. Sometimes you can find that, and that can be helpful. And this has got nice clear cell change. Also, like some true optically clear, like white looking cleared out cytoplasm from glycogen, and then other ones that are more like pale pink, right? Like right there, kind of pink. And sometimes it looks like squamoid. And then you often get a lot of basement membrane material in the background, dense collagen type 4, real sclerotic hyalinized stuff. And that's a really good clue for hydradenomas and can be seen in a variety of other sweat gland and other adnexal tumors as well. What other thing? The reason it's here, I think, in the vascular lecture is that sometimes a glomus tumor can look kind of like hydradenoma or spiroadenoma, but particularly hydradenoma, because glomus tumors have monotonous cells that all look the same, one cell type, and in hydradenomas, that's the same scenario. You have one type of cell that all pretty much looks the same, and glomus can sometimes get eosinophilic or pale or even like kind of clear cell change, and when you get those cases, they look more pink like this and not as blue as your kind of classic glomus tumor, and that can be confusing to people, and can and also you tend to have dilated vascular channels in the background of a hydradenoma. So stains obviously can sort it out. Hydradenomas will be positive for keratin, and also like most skin adnexal tumors, they will have expression of P63 or P40, and those markers will be negative in in a glomus tumor. And let's see up here. I wanted to see, does it connect to the epidermis? I think this is not taught about enough. But hydradenomas, even though they're usually big one or multiple nodules in the deep dermis or even in the subcutis, they also relatively often connect to the epidermis. And on the surface, they can, if you have a shave of the top of it, it can look very similar to poroma. And in fact, I kind of have always thought that poroma and hydradenomas are on a spectrum, although it seems like not all of them are related because poromas have a molecular difference from hydradenomas, it seems. So at least some of them may be different molecularly. But in any case, I think they can get confused with one another and can resemble one another, especially when you just have the top. So don't be surprised to see the connection to the epidermis. And that right there tells you we're not dealing with a glomus. Glomus is not going to like merge into epithelial cells of the epidermis, right? So that is That's a nice hydranoma with clear cell change. Oh, and then the last thing is, in the middle here, you could get worried that this is infiltrating, which might make you be concerned for a malignant hydranoma, or also known as hydradenocarcinoma, which you usually make that diagnosis on the nature of it having frank cytologic malignancy and or infiltrative growth. But the problem is infiltration can be quite hard to assess, especially if you don't have the complete sample. So like many other adnexal tumors, you can have this tendency in the center of the lesion to have what looks like complex infiltrative growth, but when you have the whole excision, you can see at the periphery is actually quite well circumscribed overall. Like we don't see the entire periphery, but look over here. See that? It's got like kind of a nice margin around it, and probably that's the same margin that's going to happen down below. I personally don't feel that there's a mandatory need to excise completely every sweat gland tumor. Some people like to do that. I feel like that's a little bit overkill personally, but different people have different opinions. So just the main thing is if you get a fragmented area in the middle, just recognize that don't like call it malignant outright just because of these strands that are going back and forth in the background sclerotic basement membrane. Or also if you have a big cystic space, it can rupture, and that can create a background of scar and granulation tissue and inflammation in the center of a hydranoma, and you can get this same kind of infiltrative appearance that's a really kind of it's a fake, you know. It's happening as a reactive process, but the periphery again is circumscribed. So I think that's important, nuanced information about hydranoma. If in doubt, you can always say, I'm not sure, and you can have them excise it. But I feel like I see this kind of pseudo-infiltrative pattern pretty often in these, and it doesn't really worry me. Maybe here's another example over here. All right. Hydranoma, also known as acrospiroma. 15.
So we got a punch biopsy here, and the eye is drawn to the superficial dermis, where we see little tufts or collections, lobules of something. Context clues and the histology would point to a vascular proliferation as most likely, and I think that checks out. Small little aggregations of vessels, maybe a little bit of homogenization of the kind of superficial collagen.
Mm-hmm.
Little bit of compact scale, looking for hemosiderin or red blood cell extravasation. I'm not sure I see it.
Not a lot. It's probably some hemosiderin in here, but I agree. It's not catching my eye at first glance. There may be a few red cells, but just a few. There's probably a little hemosiderin right there.
Yeah.
Maybe right here. Okay, so what do you think?
Looks like what we see on a lot of our biopsies from the lower legs, just stasis changes.
Yeah, right. And I like your point of, oh, there's some hemosiderin. Stasis change, like, this doesn't necessarily mean stasis dermatitis, right? I know you know that. I'm saying it for our viewers at home, that a lot of times that's just an incidental finding. It's useful because it tells us, A, we're dealing with the leg, and the person is certainly, I would say, an adult, and potentially an older adult. You tend to get more stasis as you get older just because gravity's had more time to fight against your blood vessels and make venous backflow pressure, which creates these little clusters and lobules of thick-walled capillaries, often with background fibrosis of the superficial dermis, sometimes with a lot of blood and hemosiderin, other times not as much, sometimes with a lot of inflammation. And then you can have a variety of reactive changes over it. I'd say we always talk with the fellows and I about like the lower leg is not a happy place for anything to live. The skin of the anterior lower leg is not normal in older adults, almost never. There's almost always stasis change, various reactive epidermal changes. You may have a overlying spongiotic dermatitis, in which case it could be true stasis dermatitis, but also it could just be contact dermatitis superimposed on their pre-existing stasis. So it's oftentimes I'll list out, if I see, in this we don't have much epidermal change, except maybe there could be a touch of like, burned out interface here, I'm not sure. But usually I'll say, oh, there's spongiotic dermatitis, there's stasis vascular changes, maybe there's some interface change. I feel like I often see those three things together on the lower leg of adults. And it's hard to know which one's the primary thing and which one's incidental. And so I give a comment to that regard. I'm not sure which is the primary thing. Also, sometimes I see single areas in people that have stasis. One area gets more stasis than the rest. and clinically looks like a red papule or plaque, and it gets biopsied because the dermatologist wants to make sure it's not a basal cell carcinoma or squamous cell carcinoma. And I don't know why sometimes certain areas stand out with more abundant stasis than others. Not sure, but it happens. And when it's real severe and you get a lot of fibrosis in the background and a lot of hemorrhage, stasis can sometimes mimic Kaposiform clinically and pathologic. So it's been called pseudo-Kaposi or acroangiodermatitis. And in those cases, an HHV8 can easily solve the problem. But stasis vascular change, a really important thing to recognize because it's so common and is an important clue in a lot of ways. Good job. Okay.
All right. So we have what looks like a kind of a pale pink kind of clear cell lobulated mass here. Kind of looks like adipocytes, but there's a little something extra to them. Guess you could think about Angioleiomyoma, but the vascularity isn't grouped quite that nicely. And then on higher power, you can see the adipocytes here have this like kind of vacuolization and a little bit of granular change. This looks like brown fat. So in aggregate, this would be good for a hibernoma.
Yeah, very good. And I like that you brought up the fact that, there's a tendency where people want to say they see extra vessels in a fatty thing, and the first thought is, oh, let's call it Angioleiomyoma. But all fatty tumors pretty much have a decent bit of vascularity to them because fat normally needs a lot of blood supply, right? Normal fat does, to exchange the lipids in and out of the adipocytes from the circulating blood, right? So that same thing is recapitulated when we have fatty tumors. They usually have an abundant vascular network. And sometimes people just don't, it's not always easy to visualize. And when you finally do see like, oh, wow, there's a lot of vessels here, it can cause a little confusion. So I guess that's why this was added, even though what we're doing today is mostly vascular things and a few mimics. I personally don't really think of hibernoma as a vascular tumor mimic, but I think it's a good point that a rich background vascular network in any sort of tumor can sometimes make people incorrectly think of a vascular neoplasm. Like, for example, say solitary fibrous tumor. It has tons of vessels, but it's not a vascular tumor. It's a fibroblastic tumor of some sort that just has a bunch of vessels in it. So here we see, though, like you said, we see three types of fat cells, okay? We see mature white fat, the same kind we see in adults in the subcutis, regular fat, basically. Then we see these bubbly vacuolated cells that look almost like lipoblasts, except they have small nuclei. They're not big, ugly nuclei, but they have the same kinds of vacuoles that you'd see in a lipoblaст, lipid vacuoles, right? And then, even though they're not abundant here, some cells have a granular, grainy, kind of oncocytic looking reddish pink cytoplasm. And that's because they're packed full of mitochondria. And you can see variable amounts of that red graininess in the background of the bubbly cells too. So those three cells in varying proportion are what make up brown fat, and a tumor of brown fat is a hibernoma. Sometimes it looks mostly like white fat, and you just get a little bit of the vacuolated cells and almost none of the bright pink or red granular cells, okay? So it can really, the proportions can vary a lot. Even though it gets taught in Dermpath, I'm not exactly sure why, because I personally have never seen a hibernoma in the skin. I don't think I'm not even sure if I've seen a good example of one in the subcutis. The vast majority I've seen are like down deep in the muscle, yeah, basically they're usually intramuscular masses on the proximal extremities of young adults. And I think they're important to know about for surgical pathologists and soft tissue pathologists because they can become kind of large, like in the 8 or 10 centimeter range, like on the large end of what a lipoma would usually do. And on imaging studies, if they do an MRI, they look fatty, but they don't look like normal fat. And the reason they don't is because they're not made of just normal mature adult fat like a lipoma. They have all this extra stuff. They've got hypervascularity, and they've got a lot of these extra cells that have more substance in their cytoplasm, and that gives a different signal on an MRI. They can have some fibrous bands. They can have stuff that makes them look like a liposarcoma on imaging. And so it's a thing that could look concerning on an imaging study and totally benign when we see it on path. And there are very rare times that liposarcomas can have some brown fat component, like a well-diff supposedly can. I don't think I've ever seen a good example of that in real life. And I have seen brown fat change in a high-grade myxoid liposarcoma one time, but it had brown fat looking cells, but it did not look anything like a hybrinoma. It looked clearly like a high-grade sarcoma. So I would say that's a really rare thing. For practical purposes, if you see something that looks brown fat like this, it's either a hybrinoma or it's normal brown fat. And again, almost always those things come from deep down. Sometimes you'll see normal brown fat around lymph nodes, particularly in kids, sometimes in adults as well. So it's good to recognize so that you don't freak out when you see this. Oh, and by the way, these will be hot on PET scan, so they can be discovered incidentally, either normal brown fat around lymph nodes or brown fat tumors. They have a lot of mitochondria, so of course they're metabolically active, and they're going to take up the FDG and give a hotter signal on a PET. So they're one of the things that can get incidentally discovered on PET. Let me, since we've sent the residents to clinic, let me show you another example of a much more robust. So reason I want to point this out is that they can look quite different from case to case, depending on how many of those red cells you get, the red granular looking brown fat. Look at that. If you don't like that, I can't make you happy. I mean, isn't that amazing? Those cells are very just loaded with mitochondria. And then you get the bubbly cells. Some of the bubbly cells have a little bit of the red granular mitochondria stuff, and then you get white fat. So it can really run a range from being more on the lipoma side and a little bit of brown fat to being much more on the brown fat side with very little of the mature white fat cells. Again, lots of vascularity. Look, even little capillary vessels. Don't get worried about myxoid liposarcoma. Yeah, they're going to look a little chicken wire because this is the kind of vessels that myxoid liposarcoma is making, but those are the normal vessels you have in the normal subcutis. And so it gets recapitulated. That's the normal kind of vascularity that fat has. You just don't always see it as much until you're in a setting like this where they come closer together. So don't be afraid. The other thing I think sometimes people get freaked out about is they see the nuclei of brown fat. And because we don't see brown fat very often, most people are not attuned to thinking, what does normal brown fat nucleus look like? Well, look, it's a round, large nucleus with a big nucleolus. That's a normal brown fat nucleus to me. That is not atypia. Do not be afraid. That's a feature, not a bug. That's what it's supposed to look like. All right? They're uniform. They're not pleomorphic, big hyperchromatic cells, but they are bigger and have a prominent nucleolus, which is quite different than what white fat looks like, mature adult fat looks like, right? So I think it's important just to be aware of that so that when you first notice that, and I only see hypernomas, I don't know, once or twice a year. I mean, they're not real common, or at least not in my practice. I don't encounter them that often. So a very beautiful and benign, relatively uncommon thing to see. And again, I've not seen one in the skin, but if someone out there has, I'd love to see a picture of it. Thank you. All right. Now you've seen two flavors of hybrinoma. Okay, case 17.
So we have kind of a nodular proliferation with a lot of blood in the superficial to mid dermis. Looks pretty cellular from here with some poorly formed vascular spaces, and again, just impressed by the amount of hemorrhage we have within this.
Yeah.
Seeing signs of hyperchromasia, maybe as we go in more, some nuclear atypia. It's giving me sarcomatous vibes. Very poorly formed little small vascular spaces. I'm presuming they're vacuolated areas, but presuming small vessels. So Angiosarcoma is what I'm afraid of here, especially with all the hyperchromatic nuclei. And as we go closer, you can see more atypia.
We got mitosis, probably an atypical mite up there, hard to tell in this scan. Lots of little capillary, vacuolated looking vascular channel spaces, poorly formed, like you said. We can get areas that are kind of solid sheet-like nodules of epithelioid cells. And sometimes they'll be hyperchromatic. Other times they'll have like a pale vesicular chromatin, but very large nuclei, way bigger than normal endothelial cells should look like much of the time. Big nucleoli, pleomorphism, mitotic activity, and the growth pattern being one thing we don't like to see: infiltrative growth, interconnected anastomotic channels, especially when there's atypia. And then again, like we've talked about many times together, the clinical context is really important in angiosarcoma to see how it looked clinically, and also what kind of patient and where on the body it is and what their history is. So if we're not always given all of that information, but that's something that if we're thinking of angiosarcoma, it's worth spending some time to try to figure that out if we're struggling in a hard case. Here, it's so ugly, and we've got nice vasoformation. I think there's no question. in this particular case. But let me go up to lower power here. One thing from low power that strikes me is it kind of looks like a pyogenic granuloma, lobular capillary hemangioma from real low power. Much more cellular than usual, right? But it's a nodule with a collarette. So that, I would say, is not real, this particular growth pattern. I've not seen that often in angiosarcoma. So that could be confusing at first. And when you look closer, this is super ugly compared to even a pretty revved up PG. Not going to look this ugly and this solid and cellular. Okay, and not going to use atypical mitotic figures. The other thing is, let's look at our context. Where is this coming from and what's going on in the background? We've got dilated vascular or lymphatic spaces, some of which have atypical endothelial cells bulging into the lumen. So this may actually be a more subtle example of the background angiosarcoma, or maybe it's not. Maybe it's a change from previous radiation. Here, like that's looked at. That's good. This is an infiltrative vascular channel. So sometimes the more solid nodules of angiosarcoma can be really challenging, especially when you can't see vasoformation or don't have much blood. So not all angiosarcomas will be very bloody. There are times where you can have almost no blood and very solid growth of epithelioid cells, and those are incredibly treacherous because they can mimic melanoma or poorly differentiated carcinoma on H&E, and you need immunostains to solve it, which is why in older sun-damaged people and a poorly differentiated tumor, I basically always am trying to keep in my initial differential, think of angiosarcoma and include an ERG or a CD31, unless I've got something else to prove otherwise. And angiosarcs can express keratin, so that can be further treacherous because it can make you think they're going to be carcinoma. But here we have a vascular channel infiltrating the dermis, lined by very atypical hobnailed endothelial cells bulging into and kind of floating into the lumen there, and more there. So these sneaky vessels can be very challenging on an excision because they can trickle out towards the edges, and sometimes they can stray far from where the main tumor mass seems to end. Angiosarcomas are usually infiltrative. I have seen exceptions that were nodular and not infiltrative, but I would say the majority are infiltrative, and so local control can be really problematic, in addition to the worry about metastases. In this setting, though, if we ignore the angiosarc and just look at the background, we've got, away from the angiosarc, stuff that doesn't look like tumor, but has big dilated vascular or lymphatic channels, hemorrhage, incredibly dense sclerotic, abnormal collagen. This is not normal dermis. This is like hyalinized sclerotic collagen with blood and hemorrhage and hemosiderin and dilated lymphatic spaces and vessels. This person has probably received radiation therapy. So learning to recognize the homogenized sclerotic dermis and the lymphatic stasis changes, because remember, lymphedema occurs in the context of radiation therapy. That's what radiation scars the dermis and gives it this sclerosis. And also, because of that scarring, it blocks off lymphatics, so you tend to get lymphedema change hand in hand with the sclerosis that you get in radiation. So it's really helpful clue that when I see sclerosis and lymphangiectasia, and sometimes you'll see hyperchromatic enlarged spindle or stellate cells scattered in the dermis, which represent what we call radiation fibroblasts or reactive radiation-induced atypia. You don't always see that, but sometimes you do. That triad of features should right away, even if you've not been told the history, you should suspect radiation history and go look it up. And then that's going to be, then I'm very worried if I see an atypical looking vascular proliferation in the setting of a radiated background. That's very concerning, obviously, for angiosarcoma. So that's what's happened here. This patient had radiation. I don't know why in this case, but they had radiation with really severe radiation associated reactive changes in the background. And then in that context, they had a post-radiation angiosarcoma arise. And what's the molecular abnormality that most post-radiation angiosarcomas have that we don't tend to see as often in sporadic, angiosarc in sun-damaged skin?
c-MYC.
Yeah, c-MYC amplification is present in the majority of post-radiation and also lymphedema-associated angiosarcoma. Very good.
Looks like there's a papule coming into focus.
Yes, case 18, a papule is coming into focus. Very good. And now what do we think about the papule?
So a lot of it just seems like hemorrhage and kind of fibrin, but to the periphery there are some more vascular appearing spaces. Yeah, like to this side, and it looks like the cells are the very small kind of cuboidal cytology of like a glomus or a glomangioma.
Yeah, very good. That's what it is. It's a glomeangioma in this case, I think. This one is pretty unusual because it's got this huge nodule of fibrin thrombus in the middle and blood. And I like that you pointed out go to the periphery, because I think in settings where you've got a bunch of fibrin and blood, don't forget to go look at the edges, because the edge is where you're going to find the stuff that actually helps you figure out what is going on here. Is this blood and fibrin in a pre-existing vascular space or in some other tumor? Or do we just have blood and fibrin, and all I can say is we got fragments of fibrin. I don't know if it's a hematoma or an intravascular thrombus. I don't know without seeing normal tissue around the periphery, right? And here we've got some tissue, but this is all like scar and granulation tissue. So probably what happened is it's got biopsied, I would imagine. See, there's scar going to the top, or maybe traumatized. I don't know. I don't know the history here, but there's a bunch of scar. It could just be that it bled into itself and thrombosed, and all of this is organized thrombus, some of which has turned into scar, some of which is still fibrin. But in any case, we don't know. I don't know what happened here. But looking at the edges, like you said, we see these round monotonous cells. They're kind of forming rows or layers, and the multi-layering or the onion skinning around dilated vascular channels is good for glomeangioma, aka glomerulovenous malformation, or Glomus tumor if it's a more solid nodule. Like I said earlier, the distinction is not really important for clinical purposes usually. And this one they look small, monotonous, and benign in appearance. So very good. So I'd call this glomeangioma with abundant hemorrhage and organizing thrombus. Let's go look over here and see if we can get some more look at the unaltered glomeangioma. Sometimes the layers can be quite subtle, like it'll really look like a vascular malformation at first, and then you'll just find some areas with very subtle layering of those blue round pericytes or glomus cells around the outside. And so that's also fine for a glomeangioma or a glomerulovenous malformation. Once it comes into focus, we might be able to see. Yeah, there's some right there. And they do tend to like kind of, if you go out to the edge of a glomus tumor or a glomeangioma, as vessels track away from it, you will tend to see the glomus cells hanging on and following those vessels, or kind of seeing a little bit of it right here. And that can be a useful clue if you're struggling to recognize a glomus, if it's a little unusual, or it's distorted by a bunch of blood or hemorrhage like this. Finding areas at the edge, and you can see this little vessel coming away, and then along it, the glomus cells are following. They're wrapping the vessel. That's their job. So that's a pretty nice example. Beautiful. Okay, case 19.
So the curtain is slowly lifted on this nodule, which has a lot of blood and these dilated, almost aneurysmal vascular spaces with a background kind of nodular proliferation of smaller cells which have more nuclei, so they appear more blue from up here. We see these little vascular spaces throughout. Coming in, we can see little kind of bent small nuclei. Kind of fibrohistiocytic is what I'm hoping they're going to turn out being, and maybe grabbing onto a little collagen at some corners, but certainly just robust cellular proliferation, some multinucleated cells in there.
Yeah.
Kind of a dermatofibroma background, but a robust one, again, with tons of aneurysmal spaces, red blood cell extravasation. I think probably good for an aneurysmal dermatofibroma.
Very good. Yeah, this is a good case because this could really trip you up, especially if you only had a partial biopsy. But also, you mean when there's a bunch of blood, I found that pathologists really tend to gravitate on the blood and the blood-filled spaces. I mean, it catches your eye, right? It's like right in your face. And then the first thought is it a vascular tumor? And I think a lot of pathologists find vascular tumors challenging. I find them challenging. I really like vascular tumors, and it's a particular area of interest for me, but I think they're pretty hard sometimes, even still after all these years. So I do see why people see that and then they worry, oh, this is a vascular tumor. And so that can cause angst, but you can have lots of things that have bleeding into them and can mimic vascular tumors at first. So I feel like schwannoma is a good example. It often has a lot of hemorrhage, and people can sometimes start thinking of vascular tumors. And then this example, like you very rightly said, is a dermatofibroma with abundant hemorrhagic spaces, so what we could call an aneurysmal dermatofibroma. Sometimes people use the term sclerosing hemangioma type. I don't really like that term, but I've seen that used for things that look kind of aneurysmal or things that are hemosiderotic, hemosiderin rich, which often kind of coexist on a spectrum. But in any case, in the olden days, people would use that term more. I tend to not use it personally, but if you hear sclerosing hemangioma in the setting of the skin, what it's referring to is actually a dermatofibroma with blood and or hemosiderin deposition, okay? But yeah, the large polypoid dermatofibromas sometimes are also problematic because we tend to not see them as often in Dermpath. We tend to see the smaller ones, right? And so sometimes though they can get very big and polypoid and protrude above the skin surface. They can ulcerate. That can be confusing. They can have blood-filled hemorrhagic spaces, and you're even getting almost like a little bit of that Masson tumor, papillary endothelial hyperplasia type of pattern in the middle of this abundant fibrin, right? So again, it's a case where go away from those spaces and look at the rest of the stuff. And like you rightly said, it has this so-called fibrohistiocytic look of spindled cells and histiocytoid cells mixed together in haphazard arrangement, often with some multinucleated giant cells. You may get some entrapment of collagen at the periphery, a little bit of it here. It's not as dramatic in this case as in some. And over top of it, you can actually see epidermal hyperplasia with blunting or tabling of the rete, kind of that epidermal induction type change we see over dermatofibromas oftentimes. So don't forget to look at the epidermis. It can provide useful clues as well. Let me look at the other piece here. But yeah, I think this one's particularly hard too because it's polypoid, and we're not often seeing polypoid dermatofibromas. So both clinically and microscopically, that can lead to confusion. I have definitely seen a particularly big, juicy, hypercellular looking dermatofibromas often have big dilated vessels like this. And plus the blood and hemorrhage, it can really make people concerned that what they're dealing with is something vascular or something not dermatofibroma. So big, juicy, cell-rich, I hate to say cellular because I usually use the term cellular dermatofibroma for ones that have big fascicles, but that term is kind of subjective, and people struggle over how and when it should be applied. But in any case, yeah. I think also you could make the argument, this one does seem to have some kind of almost foamy or frothy cells in abundance. You could also wonder if this is like a lipidized dermatofibroma, a large example of a lipidized dermatofibroma like we see in the lower leg near the ankle, so-called ankle-type dermatofibroma. And you can have that coexist with hemosiderin-rich or hemorrhagic aneurysmal dermatofibroma. So I don't know for sure. I don't know the site on this one or the history, but I kind of wondered that because it has dense sclerotic collagen areas and foamy-looking cells in abundance. So just another of the many, many different variations and flavors of dermatofibroma. Case 20.
We have a small punch biopsy, and you kind of get the sense of a busy dermis, often kind of the superficial aspect of the dermis. Just some increased cellularity and maybe a little blood.
Yeah,
and
a little
then
blood.
You can start to see some slit-like vessels up top, or what look like some potential like slit-like spaces, and then maybe some spindled cells kind of interstitially.
Yes.
So and then on higher power you can really see that there's actually a lot of slit-like vessels containing erythrocytes. So not really the morphology of Angiosarcoma, but kind of would keep that on the differential, but this would be good for Kaposi's.
Very good. This is nice Kaposi sarcoma, probably the patch stage, or maybe starting to get into the plaque stage. Clinically, I think it's labeled in the answer key as patch stage Kaposi. But there's a kind of a spectrum there of changes. But this one at least already has a significant obvious alteration. The dermis does not look normal. Like for this patient, their normal dermis is more or less down here. And this is way more dense collagen, more cellular, more hemorrhage. There's something going on in the upper part of the dermis that's not normal. So that sometimes is the main clue we get. But in very, very early Kaposi, the earliest patch stage can be extremely subtle and not have much of the sclerosis, and those can be really easy to miss. So this one I think is more obvious. We know something's going on here. And once you look closer and know to think about Kaposi, it becomes pretty easy to make the diagnosis. I think one problem is we always learn slit-like spaces and blood. But we have a problem here. Is there's slit or cleft-like spaces between the collagen bundles. Here, that's just like that artifactual splits that we see between the collagen bundles and the normal dermis. So it's kind of a cracking artifact almost. But then here, what we're looking for is the slit-like spaces are these, the ones that are lined by endothelial cells. So there's little spaces in between these spindle cells, and the spindle cells are trickling out between the dermal collagen bundles, sometimes wrapping around them. And like you said, we could always think, could there be angiosarc that's subtle also? But here, what we're looking at doesn't look very atypical. Most of the time, angiosarc has a lot of atypia, and Kaposiform doesn't have much. There are exceptions in both directions, but still, I agree on a test and also in real life, I would be much more in favor of this being Kaposiform. And we have the slit-like spaces with blood, and then also in some areas, the cross-sections showing that sieve-like pattern that Mark Edgar taught me about, the little holes that are round, and the cells look more around the nuclei rather than spindle because we're getting a little small fascicle that's starting to form and is coming out of the screen at us and cut in cross-section. So this could get confused a little bit with stasis. Stasis can look a little like this. So the key, I think, is seeing the blood in the cracks, which are lined by endothelial spindle cells, trickling into the spaces. So these are not well-formed vascular channels. They're kind of immature, primitive vascular channels. And if you do endothelial markers, you can tell that all these spindle cells that look a lot like fibroblasts are actually endothelial. And that's where that can also help you say you don't have HHV8 readily available. And your between is this severe stasis acroangiodermatitis, which with a lot of hemorrhage and spindled scar-like background, or is this true Kaposi? One thing you can do is to do a marker like CD34 and see, or ERG. CD31, actually, this is one context where 31 doesn't work quite as well because the HHV8 virus tends to downregulate the CD31 molecule. And so CD31 can be diminished or even false negative in Kaposiform, which I thought was really interesting. Leon Pantanowicz and a colleague described that in the literature some years back, and I thought that was a useful clue. I don't honestly usually do vascular markers here. I just go straight to HHV8. So I am not as familiar actually with seeing those nuances because thankfully we have HHV8 stain available now. In the past, people had to go really on morphology before the HHV8 stain was developed. Which was a much more problematic situation. But anyway, what you'll see, though, is that the spindle cells in the background of stasis are fibroblasts. They are not actually infiltrating spindled endothelial cells, so they'll be negative for endothelial markers, whereas here, these will all be positive. A couple other clues. In addition to blood, there's often hemosiderin, and then also, we often have plasma cells. Plasma cells are really common around Kaposiform for some reason. Now, that's not totally specific. In people with chronic lymphedema, they also often have a lot of plasma cells. For some reason, plasma cells like to hang out in the setting of lymphedema. And particularly in people that get the conventional or the classic form of Kaposi, the older adults with lower extremity Kaposi, guess what? Older adults sometimes have lymphedema, and particularly Kaposiform tends to have background chronic lymphedema changes. I don't know which one causes which or if they coexist for some other reason. Sometimes chronic lymphedema can have, there's a thought that in areas of chronic lymphedema, because you don't have good lymphatic flow to the lymph nodes, that area kind of forms a regional immunosuppressed area. So it may be that the chronic lymphedema is causing less immune surveillance of that area. And accordingly, the HHV8 virus can run amok there. And that's potentially why the Kaposiform starts showing up in the lower extremity more than elsewhere in older adults. It may be that they have systemic decreased immunity, but also it may be that they have regional decrease because of lymphedema. So it's a really interesting question, but I think it is important because people with lymphedema tend to get abnormal looking skin, and then it can be hard to sort out what's just lymphedema changes and what's actual Kaposiform, and sometimes you have both hand in hand. So anyway, just be aware of that they often do coexist. And I think I saw it over here on the other slide. We published Josette McMichael and myself and Ben Stoff, one of my other mentors at Emory, and some of our colleagues from Afghanistan and some of our residents here in the U.S. We collaborated together and did a series of cases of Kaposiform from Afghanistan. And some of those patients, most of them were the classic type in older adults, and some of them did have pretty dramatic background lymphedema type changes. So we published that a couple of years ago. It was a real great honor to collaborate with our colleagues in Afghanistan who do an incredibly difficult job without the benefit of immunostains or subspecialization, and do great care for the people of that country. So true honor to work with them. All right, here's some more of those spaces. I wanted to show you over here one thing. This is not the best example, but there's a little bit of a promontory sign here. A vessel kind of pushing into and protruding into the lumen of another vessel. So vessel within a vessel growth. You can kind of see it here. It forms like a promontory or a little mound or a hill inside the vessel. Sometimes those are like pre-existing dermal vessels that are normal, getting wrapped around by a thinner, dilated slit-like Kaposi vessel. And so that's a feature that's often talked about, but I would say that I only see good promontory sign in a small subset of cases of Kaposi. So it's great when you see it, but don't count on that to make the diagnosis. Many cases will not have it or will not have a well-formed promontory sign. But really good to just train your brain. When you see trickling little spaces or small vessels that are not organized, that are trickling into the dermis with hemorrhage and blood between them, think of Kaposi. If there's any doubt, go do stains for it. That last thing that I was thinking before I got distracted was to see, nope, I think this one's not progressed far enough. When eventually, once they grow kind of more towards plaque stage, they get down deeper into the dermis, and they will begin, those little slit-like vessels will infiltrate and crush the eccrine coils. I don't know why, but for some reason they seem to love to grow into the space between the eccrine sweat glands and to squeeze them and fill up that space. So you'll see spindle cells and blood and hemosiderin and atrophic looking eccrine coils, and I find that really helpful for a diagnosis of Kaposi sarcoma. We don't have that here. It's kind of too early for that here. I've got a nice example on Kiko that has a nice promontory sign and nice crushing infiltration of the eccrine. Oh, maybe here. That is Kaposi here, but I don't think it's around the eccrine coils yet. Oh well. Anyway, you can go look up that one on Kiko. It's a nice example.
So we got a cute little papule here with a lot of open white spaces, presumably once filled with something, but probably not blood because I don't see a lot of erythrocytes. A little bit of serum probably in the central portion of both of them. The walls look very, very wispy thin, so lymphatics is most likely. So lymphangioma, I think, would be the best diagnosis here. Not really seeing a muscular, thick-walled vessel anywhere, and again, not a lot of blood, thin walls.
Very good. I agree. This one's kind of polypoid in appearance, lymphangioma, and in reality, probably most, if not all, of the things that we call lympangiomas are actually lymphatic malformations. And as you know, that's also a problem with vascular things. We call lots of things hemangioma. Some of those actually are probably malformations and not true neoplasms. It doesn't always matter. I think in lymphangioma, it's worth knowing, though, that there's often a much deeper unsampled component with these because they are malformations and they can track down quite deeply sometimes. And because of that, they can be, problematic management depending on the site. If they're in an anatomically sensitive site like the genitals and they're larger, they can be, problematic. They can sometimes weep and leak fluid out of the surface. The classic look is like the clustered, skin-colored, slightly translucent papules that look like frog eggs or frog spawn appearance, so the lymphangioma circumscriptum. And then there are other forms like the very large ones that are in the neck area, particularly common in patients with Turner syndrome, so the cystic hygroma. All of these are different variations or presentations of lymphangioma, aka lymphatic malformation. Like you said, very dilated cavernous spaces with very thin walls and thin flat endothelial cells. Usually, for practical purposes, if you see a lot of pink stuff that looks like serum and not much blood and the thin-walled vessels, then vote for lymphatic. In real life, it's sometimes hard to tell. I have seen spaces like this that I thought for sure would be lymphatic, and then I did the markers. I did D240 or protoplanin, which is positive in lymphatics but not in vascular endothelium, and it was negative in these. Sometimes in real lymphatics, like in this case, these would all be positive for D240 as well as other typical vascular endothelial markers, CD31 and ERG. CD34 can be a bit variable. Sometimes it stains lymphatics, sometimes not as well. Doesn't really matter, but just so you know. But yeah, if you really want to know, you can do the D240, aka that's the molecule, the antibody name that detects the antigen podoplanin, which is expressed on endothelial cells. Anytime there's more than one name for an immunostain, it's worth learning them all, because for testing purposes, you never know which name they're going to ask you. If they ask podoplanin and all you knew is D240, then you might miss the question even though you knew the content. I think it's frustrating, and I personally think that test writers should probably include if there's two common names, put one in parentheses, because you want to test knowledge, not esoterica, but I don't make the rules or write the exam questions in general. So, all right. But my point is that sometimes I have seen stuff that looked so much like lymphatic in real life, and I did a stain and they ended up not being. Because what happens is sometimes in vascular channels, after the tissue is removed from the body, the blood can settle, and so the red cells settle out, and you get areas that are filled with serum. And serum and lymph are like very similar, right? They're fluid that has protein in it, but not cells. And so they'll look pink and kind of cracked like this in the spaces. So I've seen vessels that have serum that don't have much blood that look very similar to lymphatics. And also I've likewise seen sometimes lymphatic spaces that get blood in them because blood has spilled into them during cutting when we gross dissect the tissue and process it in the lab. So, but on a test, I would say pink filled spaces like this, call it lymphatic. In real life, it could go either way. Sometimes you can get a clue. You can see histiocytes floating in lymphatic spaces, both in dilated lymphatics in the body for non-vascular lesions, but also in the setting of lymphangioma, lymphatic malformation. You can also see lymphocytes in the lumens or around the walls. Sometimes you'll see like nodular aggregates of lymphocytes, even with germinal centers around these spaces, and that's a really good clue. If I see this with a little lymphocyte aggregates around it, that's great for lymphangioma/lymphatic malformation. And some malformations can have lymphatic and venous components. They can have a mixture of components all mingled together. All right. So this one, lymphangioma or lymphatic malformation, really good example of it here. Very nice. Oh, and the last point I was going to make is, look, you can get entrapment of vessels in these that looks quite like angiokeratoma. So to me, lymphangioma, angiokeratoma, Targetoid hemosiderotic hemangioma, and post-radiation atypical vascular lesion can have areas that look almost identical to one another. The nuance of sorting them out is based on, is there blood or not? Are there slit-like spaces underneath and hemosiderin? Is it occurring in a radiated site? All of those things are the nuance of sorting between this, but they can, to me, look quite similar and overlapping. So if you struggle to tell those apart, it's because they look alike. That's why. Oh yeah, and also, we got hobnail cells. Hobnails are everywhere. Don't get too worried about the hobnails, okay? They're only useful when you want them to be useful. I mean, that's kind of true. You guys are getting like the full fellowship lecture here, but
no, it's good. So speaking of things that kind of have a similar, I guess, superficial appearance, there's like a little bit of papillomatosis, some acanthosis, and some dilated blood-filled spaces up top. And then kind of superficially, there are some smaller vessels diving down a little bit deeper. So, I mean, I'd consider angiokeratoma for the top part, but it goes way deeper than what I'd expect for that. So, a verrucous hemangioma would be for this.
Yeah, that's very good. We don't see these that often. And the top of verrucous hemangioma, of course, is going to have a verrucous look on the top. The problem is I see lots of vascular things that look a little papillomatous like this. Number one, this particular example is not incredibly verrucous. I mean, a little bit, but it's not, you would never look at this and think, oh, it's a wart. You're going to look at the vessels and think this is a vascular lesion, right? And also, I've seen a variety of other things that have been picked at and traumatized and get some prurigo change over them and are not verrucous hemangioma, but look a little verrucous on the top. From reading, the important distinction people have made with true verrucous hemangioma is that usually, they're probably, I don't know if they're really a neoplasm or malformation, but the big thing is they go deep. They often go deep, and I tend to think that the current thought is that they may be malformations. But they often have a much deeper component. And look, we can see that here. We're all the way down in the fat, and we still got lots of vessels. So the problem is if you just do a shave, you're going to be leaving a lot of lesion behind. It is benign, but the point is it can recur, it could bleed, it could ulcerate, So it can be a little bit more difficult to manage or remove because of how deep it extends into the underlying tissue. And so that's typical of a true verrucous hemangioma, which again, to me, this looks like a malformation. We got vessels of varying size, some of which are veins with thick walls. But that's the key to like the real verrucous hemangioma is they're supposed to be deep like this and have a verrucous surface. And we have variable different types of vessels. And they do kind of, air quotes, infiltrate. They interconnect with all the different tissue, but each of the vascular spaces is well formed. So that's kind of the difference. We talk about angiosarcoma as being infiltrative, but there are many other things that are not well circumscribed and have vascular channels that intermingle with normal tissue. The difference is that in angiosarcoma, A, you have atypia, and B, you have channels that are wrapping around normal structures. Here, we have normal, well-formed round to oval channels that are just spaced in between normal tissue, not like wrapping around and diving between them. There's kind of a difference in the pattern. I feel like that sometimes confuses people because they say, well, how is this not infiltrative? But it's just that it's intermingled, it's intermixed, but it's not actually aggressively diving between each individual piece. I recognize that can be hard, and I don't know that I'm explaining it as well as I could, but in any case, sometimes that comes up. Some of the channels here, look, these look a little more, look at the nice hobnails. See, I told you, hobnails are everywhere. We got channels that are much more, smaller and have more plump hobnailed cells here that look different from those bigger ones down deep. And then up top, they look, take that little bit of blood out, we could call that lymphangioma. We could say it's the top of a targetoid hemosiderotic hemangioma. You really can have a lot of overlap in the surface of these sometimes. So it's also okay to say benign vascular proliferation and say I can't subclassify it on this shaved biopsy, or to say hemangioma. If I've excluded other things, like if this is not a radiated site, I can say this is benign. And if I want to know if it's lymphatic or not, I can do a D240. But even still, I can say it's benign and vascular, or it's benign and lymphatic, and I can't exactly subclassify it. The subclassifying, once we've ruled out malignancy, the subclassification is often less important. There are exceptions, but it's not as important clinically.
Well, we got a little kind of lobule or a small nodule of vascular channels, and usually we see small little thin-walled channels when we get biopsies in, but this has both thick and maybe at the periphery in particular, somewhere thin-walled, so probably good for a true arteriovenous malformation or hemangioma. Hemangioma is probably a better term.
Yeah, good. That's right. And I know you're saying it with caution because you know I'm about to lash out at you. Just kidding. But because it's not my favorite term, but in dermatopathology, these are called arteriovenous hemangiomas. The reason I don't really like it is that it sounds a lot like arteriovenous malformation, and true AVMs usually are in deep soft tissue. They have high flow to low flow on a Doppler ultrasound. And these are just, what we're looking at here is not that. This is not like a real arteriovenous high flow to low flow situation. These are actually just a hemangioma or a malformation, I'm not sure which, that have a pattern of thick-walled vessels that to some people look like arteries and veins. Well, I'll tell you this, all arteries must have some, all hemangiomas and vascular lesions have to have some arterial flow. How's the blood get there otherwise, right? It has to get there through arterial type things. And I would also argue that if you look at these, they are probably not real arteries, most of them, because they don't have internal elastic laminas, right? They're just thick, muscular walled, probably mostly venous channels. But in any case, for testing purposes or teaching purposes, people like to call this an arteriovenous pattern or type of hemangioma. I just would call this benign hemangioma or benign vascular malformation. It doesn't really matter, but that's what people classically teach these as arteriovenous hemangioma. But I think the main point I'd make is that this is different than a true AVM, arteriovenous malformation of deep soft tissue. This is not the same thing. But they're just a benign hemangioma or malformation that has thick muscular walls around many of the vessels, and then some that are thinner. And like you said, the vessels look quite different. It is a very distinct, recognizable thing, whatever name you want to call it. It definitely looks different than a capillary hemangioma, or a cherry hemangioma that we see all the time. These look different than that.
So there's in the deep subcutis, there's kind of a multinodular proliferation of, looks like kind of endothelial cells with some blood spaces, kind of dilated. It looks like there's kind of this background cellularity too of these more spindled cells.
So yeah, there's, like you said, there's some cavernous spaces, and that's what we're seeing here. We got blood and some serum and these dilated, and cavernous just means big open spaces, right? Often with thin walls. That's when we say cavernous, that's basically what that term means. It's just big and open like a cave, like a cavern. And sometimes you can see these little bubbles protruding into the serum. You can see that in this entity, but in lots of different vascular things. It's kind of normal to see endothelial kind of vacuoles that have protruded out and pushing that serum out of the way. And then in addition to that, the cavernous areas, we also see background that are kind of more cellular spindle cells, right, with some blood between them. And let me go over to another area over here. This doesn't look as cavernous. This is more like kind of almost solid nodules that are cellular. Both spindly here on the left and also kind of epithelioid looking here on the right. So do you have ideas how we put all this together? What is this thing called?
Yeah, altogether this would fit for a spindle cell hemangioma, but it does look pretty revved up and kind of scary.
Yes, that's why it's good to know about this entity, because it looks kind of scary if you don't know what it is. Once you know what it is, it's a very characteristic lesion that's easy to recognize and diagnose, usually on H&E. If you really, to me, the only other thing that could kind of look like this would be maybe Kaposiform. But I would tell you that Kaposiform is not as common nowadays, thankfully, because AIDS is not as common in our practice setting, at least because of antiretroviral therapies. So we don't see Kaposi's nearly as often because we don't see uncontrolled HIV as often. But in the cases of Kaposi I've seen, I don't think I have personally ever seen a case of Kaposi present as a subcutaneous nodule without dermal involvement. Essentially all the Kaposis I've seen start in the dermis. They may get down into the subcutis, but they are basically dermal centered or dermal beginning processes, with the exception of rare cases where I've seen like lymph node Kaposis and stuff like that. But to present as a solitary nodule down in the subcu is not a typical Kaposisarcoma presentation. But if you got any doubt, HHV8 stain will be negative here and will solve this problem for you. This tumor, spindle cell hemangioma, most of the time when I've seen it, it has been a single or multilobulated subcutaneous nodule, although it can sometimes occur in the dermis. And in those cases, it can bear more close resemblance to Kaposisarcoma. And Kaposi can have dilated cavernous areas. It can have spindle cell areas like we talked about earlier. It can have epithelioid looking cells sometimes. Kaposi can have a lot of different patterns and flavors. So if there's any doubt, again, do the HHV8 stain. But what we usually see for spindle cell hemangioma is from low power. It's often a nodule or multinodular subcutaneous mass, and it tends to be biphasic. You have dilated cavernous vessels. This one looks very busy also because there's so much blood in it. Sometimes when I see them, the blood is kind of washed out more during processing and is not so abundant. So the blood here, I think, makes this look very, very busy and gives it a more scary appearance to our eye. But even without the blood, we see cavernous areas, but then we see solid cellular spindled areas and epithelioid areas. That generally makes us worry. When we see a vascular thing with solid areas, we feel afraid because there are a variety of bad things that do that, right? And it's not as often to see solid areas in benign vascular things. So I think it's important to bring up that in the spindled areas, the spindle cells are elongated, kind of vague, fascicular, intervened with some compressed channels, some of which look slit-like, kind of like Kaposi, okay, a little bit. But also, I think the name doesn't really imply the fact that usually we will also see epithelioid areas as well as the spindled areas. So I would say this is common finding, not like a rare exception. Usually there will be some sheet-like or apparent sheet-like nodular epithelioid plump endothelial cells. Again, even though this looks solid, if we do an endothelial marker here, 31, CD31 or ERG, we will see that there are actually nice, well-formed vessels. They're just packed very closely together, and many of the lumens are kind of obscured because they're squished against one another, as is often the case in vascular tumors that have epithelioid cells, like epithelioid hemangioma. It looks like they're solid, and then on immunostains for vascular markers, you see there's actually much more organization and well-formed pattern here than we thought. They're not really sheet-like, okay? The cells are plump, but they are pretty bland, and they don't have much in the way of mitotic activity or pleomorphism or atypia, okay? The other thing I was going to bring up is this is an entity where CD34 is often negative in much of the lesion, which is an interesting phenomena, that even though these are vascular, they often do not express CD34 or have big zones that are CD34 negative. Yet another reason that I don't love using CD34 as a vascular marker in general. I actually, my resident Rahil Rizwan was the first person who showed me an article in the literature from years ago, actually, that said this. I had not really stained these very often, because usually if you get a nice sample, they're pretty recognizable once you're aware of their features. So I had not stained them, and I don't use CD34 that often, so I wasn't aware of this feature. Maybe I skipped that day of fellowship. I don't know. I'm looking for one other feature that I like in this entity. These are relatively rare. You don't tend to see these as often, although I've seen a run of them in the past few years for some reason. Before that, it would be several years between times that I would encounter these. They are benign, but they tend to be multifocal. So you can have multiple nodules in the same extremity, like on the right leg, for example, or the arm. Tend to be the extremities of adults, and they can be multifocal, and they can arise out of the wall of a vein, and they can even extend into and fill the lumen of a vein. And so that that growth into the lumen of a pre-existing large vein, and the fact that they can be multifocal or multinodular in the same limb, can make them look very scary clinically, right? That presentation clinically, intravascular growth and multifocality, sounds like you've got something that's beginning to metastasize. And that's why in the 1980s, when Dr. Weiss and colleagues described this, they thought at first that it was a type of intermediate malignant potential vascular lesion, and they called it spindle cell hemangioendothelioma. But when they followed those same patients up over a decade later, none of them had any progressive disease. So these can be multifocal, and they can recur, but usually after many years and not in an aggressive fashion. So they are now renamed as spindle cell hemangioma, but I think it's worth knowing that they can be multifocal, and that's not at all an indication of malignancy here. What I was trying to find was that endothelial vacuoles sometimes clump together and look like little tiny fat cells crushed in the middle of the cellular zones, but I'm having trouble finding it. I've got a really nice example of that on my Kiko index, a digital slide of that. And it's not always present, but when you find it, it is very characteristic of spindle cell hemangioma. And I am just not seeing it here, so I guess I'm going to let it go. This one does have a vein in the middle of the lesion. I'm guessing that probably is what the lesion arose out of, this vein probably here. See, there's this big muscular vein here. But I can't see it growing into the wall of it, but I've seen that before. I think that the case on Kiko that has the nice vacuoles also has nice growth right into and through the wall of an adjacent muscular vein. A really, really pretty example that you'll, I think, look at and think it has a lot of overlap with the case we're looking at here. So benign and beautiful, spindle cell hemangioma. And what is the syndrome? These are, when I see these, they're usually sporadic, but there is an association with a certain syndrome. And what's that? Maffucci syndrome, where people have IDH1 or IDH2, usually IDH1 germline mutations, and then they develop multiple enchondromas of bone as well as spindle cell hemangiomas, and they have a higher risk of developing chondrosarcoma of bone as well. And then also I was just informed the other day that Klippel-Trenaunay syndrome is supposedly can have spindle cell hemangiomas in it as well. I've seen a couple patients with Klippel-Trenaunay, and all the things I saw in them looked like big vascular malformations, but I don't recall ever personally seeing a spindle cell hemangioma, but I've been told it's reported as an association. So in any case, and even the sporadic spindle cell hemangiomas usually have mutations of IDH1 or IDH2. So if you're struggling on a case, you can send it off for molecular testing to find that malformation. And if you happen to have the IDH1 immunostain in your lab, like for staining gliomas, my understanding, if I recall correctly, is that the locus of the mutation, or the mutation is actually different than the glioma mutation. And so the immunostain does not usually work on these. Even when they're IDH1 mutated, the IDH1 immunostain is usually not going to stain them. That is my understanding. I've tried it a couple times just to see, and it came out negative, even on cases that we ended up later sending for molecular testing and were positive on molecular. So I think that's probably true, that at least the formulation that I've had in my laboratory of IDH immunostain has not been helpful in identifying these. But again, with practice, these are pretty recognizable in H&E. Case 25, what's this?
So this is blue, pale, and hypocellular, kind of a lobulated nodule. So the blue hypocellularity makes me think of myxoid, and we certainly can also see there are small vascular spaces in here.
Good.
So put those together and we could get an angiomyxoma.
Very good. There's a nice example of superficial angiomyxoma, which in my opinion is the same exact thing as cutaneous myxoma. And I think that's important because the cutaneous myxomas look a good bit different from like deep intramuscular myxoma. So those are both called myxoma, but they are probably two separate things because they don't look like each other. The cells may have some similarity. You have myxoid change with hypocellular bland spindle cells. Sometimes you get these kind of bean-shaped nuclei with little blobs of pink cytoplasm. I feel like those are more commonly seen in the deep intramuscular myxomas and not as much in the superficial cutaneous myxomas. But the main difference is that the vascularity is more abundant in cutaneous myxomas, which is, I think, why the name superficial angiomyxoma is apt, because you will see a lot more vascularity, and they tend to be these branching vessels in this multilobular hypocellular myxoid bland spindle cell proliferation, okay? And the vessels, the branching vessels in the myxoid could make you worry a little bit about myxoid liposarcoma, but really only if you've never seen a myxoid liposarcoma, because once you've seen one, this doesn't look anything like. I mean, there's blue and hypocellular, and it's got some vessels, but the pattern is really quite different. Also, I have never personally seen a myxoid liposarcoma in the skin. It has been rarely reported, but I've never encountered one, and I've diagnosed many myxoid liposarcomas in my career. They are almost always deep intramuscular lesions below the fascia, very rarely in the subcutis, but in any case, extremely rare. And the vessels here, even though they are branchy, they are much thicker walled than the very delicate capillary-sized vessels of a myxoid liposarcoma, okay? So in any case, we do have abundant vessels that branch, bland spindle cells, hypocellular with a myxoid background, usually multilobular. Sometimes the lobules will get a lot of like sclerosis or fibrosis dividing them. We're beginning to see that subtly here. Like see there's pink collagen kind of wrapping around this lobule. So the multilobularity is pretty helpful. Other things you can see but you don't always see is scattered neutrophils. It's a really great finding because not a lot of things have scattered random neutrophils in the background. We see scattered lymphocytes and all sorts of stuff, but scattered neutrophils is kind of unique. Okay, so if you see something like this and then there's scattered neutrophils floating around in the myxoid stuff, that's a great clue for cutaneous myxoma, aka superficial angiomyxoma. The one caveat I'd make is if you've got an ulcer on the surface of a lesion and there's some, neutrophils impetiginizing the surface of the ulcer, well, guess what? You're going to see scattered neutrophils in the dermis down beneath, regardless of what it is, because the neutrophils have to come out of the vessels to get up to the ulcer surface. So anything ulcerated, the kind of scattered neutrophils is kind of is off the table. Like you may see them, but they don't mean anything necessarily, right? So that's one clue, though, especially for test and real-life purposes. If you see scattered neutrophils in this myxoid lesion, that's a great clue for angiomyxoma, cutaneous myxoma. Like many myxoid things, mast cells are often hanging around, but that's true. If you see blue myxoid stuff, you're often going to see mast cells in the background. That's just a kind of mast cells. Mast cells are like pigs. They like to wallow in mucin, is what Ron Rapini always liked to say. And I think that's kind of funny. And, for anyone watching this as a pathologist, in Dermpath, we use the terms mucin and myxoid kind of interchangeably. So if you hear me saying mucin, I mean myxoid. I don't mean epithelial mucin. I mean this glycosaminoglycan stuff that we're looking at in the background. The last thing, this one doesn't have it, but sometimes a subset of cases, maybe 25% or so, of cutaneous myxoma, superficial angiomyxoma, will have entrapment of adnexal structures, often with kind of distortion or cystic change and dilation of those. That can either be sweat ducts, or hair follicle type structures with cystic change, sometimes with keratin granulomas because they rupture. And so finding those things in the background of a myxoid lesion like this is a great clue for superficial angiomyxoma. Some people, Tim McCalmont made me aware of this, online on Kiko, he posted about this, that some cases, and he believes that some of these things that have been called superficial angiomyxoma with entrapped adnexal structures maybe actually represent adnexal tumors like variations of trichodiscoma or other hair follicle tumor that have abundant myxoid stroma. So it's kind of a chicken or egg question. And I have seen some cases, I'm glad he brought that up because I didn't know how I felt about that at first. Maybe it's because I'm biased as a soft tissue pathologist and wanting to make things into soft tissue tumors. But I have seen cases that really looked like angiomyxoma and then later on excision really looked like they had hair follicle proliferation. So I don't know which name we give them. They are benign either way. But I think it's worth knowing that overlap exists, and there have been questions about what the actual origin is of some of these. And I would like to bring up that in this case, even though we don't have entrapped adnexal structures, look what we have up top. We've got this kind of poorly formed, once it comes into focus, hair follicle epithelium kind of on the surface. It will show blue basaloid cells with palisading and probably some stromal condensation underneath if it ever comes into focus. Well, that's what's happening there, just trust me. In any case, so just interesting, almost like the induction change, follicular induction over a dermatofibroma. So these are interesting. The main problems that people have here are these, okay? Number one, if you get a small sample, how do I know it's this versus, say, other myxoid things like pretibial myxedema or focal cutaneous mucinosis, aka focal dermal mucinosis? Well, number one, it doesn't hugely matter to tell focal cutaneous mucinosis from superficial angiomyxoma. I would say this: multinodular, prominent vessels, larger, extending deeper, all those things would make me want to call it cutaneous myxoma, superficial angiomyxoma. If it's just a small intradermal, hypocellular myxoid area without many vessels, I would probably just call it a focal cutaneous mucinosis. Occasionally on a small shave, I've said bland hypocellular myxoid proliferation or hypocellular myxoid lesion, and that I can't tell if it's superficial angiomyxoma or cutaneous or focal dermal mucinosis. And then it probably doesn't really matter. If you've got clinical and it's a tiny papule, it's probably just focal mucinosis, which is just an incidental curiosity that gets biopsied to make, because sometimes people wonder if it's a nevus or something else. All right. The other problem is that sometimes you can have areas in myxofibrosarcoma. In the low-grade end of myxofibrosarcoma, you can have areas that look quite similar to this. They can be hypocellular, bland, and myxoid. So if you see something that looks like this and it's on the extremity of an elderly adult and you're only seeing a partial sample, you may want to say, I don't see any atypia here, but it's broadly transected at the edge of the biopsy, and I can't evaluate the entire lesion. And if there's any, if it's a big, deep mass, it may be worth going and removing it or getting a much deeper biopsy to make sure that there's no atypia. Because myxofibrosarcomas often involve the skin on the extremities of older adults, and they can be very hypocellular and bland in some areas. And then once you see more of it, you can see that they're infiltrative and have atypia. And they can be a management problem, and they require large surgery with big margins. So that can be problematic. And what you want to see for those is really big, ugly, hyperchromatic cells. You must have at least some ugly, hyperchromatic spindle cells to make a diagnosis of even grade 1 myxofibrosarcoma. It must have some pleomorphism, or else you can't diagnose it without that, okay? Here we have a couple cells that are a little bit bigger. That's not what I'm talking about. They got to be like ugly cells, okay? So you can see I've got examples of that on Kiko. And then the last thing that comes up with these, and I know I'm belaboring this, but that's because I see people struggle with myxoid lesions, particularly this entity, a lot. Because they wonder, is it something else? Is it this? And what does this mean? And do I have to worry about Carney syndrome? Yeah, Carney syndrome will often present with cutaneous myxomas, but they will often have multiple myxomas, or they'll have myxomas particularly in a couple of sites. The ear, near the eye, or on the nipple. For some reason, Carney syndrome patients tend to develop myxomas in those sites. So when I see a solitary superficial angiomyxoma, I don't always say that, oh, they have to screen the person for Carney. Sometimes I will mention that these can be seen in the context of Carney syndrome. but particularly if they're in one of those 3 anatomic sites. And the last thing is, what about deep or so-called aggressive angiomyxoma of the genitals? Usually in women, in the vulva, the difference is the size and location. Superficial angiomyxoma is going to be a couple centimeters, and in the skin, maybe pushing down from the dermis to the subcutis. Deep angiomyxoma, or air quotes aggressive angiomyxoma, because they're not really aggressive. The problem is that they're big and deep, and because of that, they're hard to remove because they grow into the pelvic soft tissue around the vagina, around the uterus. So they are a deep soft tissue thing that sometimes pushes up to the skin. So the biggest difference there is the clinical information. How big and deep is this? If there's any doubt, you can recommend an ultrasound or some other imaging study, or just, clinical exam. If this is a small nodule that's 2 centimeters on the vulva, it's going to be a superficial angiomyxoma. And yes, these can occur on the vulva and in the genitals. Okay. These deep angiomyxomas, in my experience, and I've not seen many of them, but they don't look this myxoid. They usually look more like edematous pink collagen with pale edema areas, and they have vessels of varying size, including big thick wall vessels, and they're very deep into the soft tissue and large. Okay, and they also, I think, usually have HMGA2 mutations, so if there's doubt, you could send out for that. I've not used that personally, but it is a clue that a test you could use if you were struggling. But I feel like people often send in any sort of myxoid lesion in the genitals, and they're always worried about deep angiomyxoma. And I would say most of the consult cases I've seen over the years that were sent in for rule out deep angiomyxoma ended up being something else, not deep angiomyxoma. So it's an important entity to keep in mind, but I think that it's often overly worried about and ends up being something else. So I don't know if that is helpful, but there's some features that you can use. And I've got examples of a true example of deep angiomyxoma and a video on Kiko. Okay, case 26.
All right. So we have a kind of superficial shave here, and really all we see are these dilated kind of vascular spaces, like thin-walled spaces. So things we could think about, like cherry angioma, but they just seem kind of like loose and just a dilated space.
Yeah, too big, right? Exactly.
Yeah. So venous lake.
Yeah, very nice. This is good for a venous lake. And sometimes, depending on how much of a biopsy you have, you could wonder, like if, say we just had this could just be a big telangiectasia, right? Like those little guys there are telangiectasias, spider veins. If you're at home watching this and you're not as familiar, that those are the dilated kind of branchy vessels that become more common in the skin of sun-damaged people. So we do have some telangiectasias here, but also we've got something that's much bigger and more irregular and lined by very thin, bland endothelial cells and have the thinnest little collagen wall possible. And so these are venous lakes, and the blood often washes out of them, I find, during processing. So they often are empty like this and not blood-filled when we get them on a biopsy. But in the patient, when they're under pressure from, the normal blood flow, they actually are much more dilated and look like a kind of violaceous little papule on the face. And then once they cut into them on biopsy, that blood, spills out at the time of biopsy and then is washed out during the fixation and processing. So we just get this thin-walled space. Like I said, you could wonder about telangiectasia if you just had a small sample. You could also wonder about maybe a hydrocystoma. But a hydrocystoma, if you look closer, will actually have a true double layer of cuboidal epithelial lining, whereas here we have a flat single layer endothelial lining. If you were really struggling, you could do stain. But yeah, that's good. Nice example of a venous lake, often on the face of adults. And it's one of those things too that depending on how deep the shave is, you might not you might have a shave like this. I can't center it, but where the shave looks all kind of normal, you see, I don't know, some telangiectasias, I don't know what, and then at the very bottom edge of the shave is the top of one of the big dilated channels of the venous lake. Kind of like in hydrocystoma, you can just see it nicked at the bottom. So the very bottom of the dermis at the bottom of the shave biopsy will be lined by hydrocystoma, or in this case, lined by a little layer of endothelium, and you're at the top of the venous lake. So that can be kind of helpful. But usually knowing the clinical that they were thinking of a venous lake will help you to make sure that you go look down there. You can sometimes on deeper sections you'll run into that if you're struggling to find a diagnosis to make sense of the clinical. Cut a little deeper and you might find the venous lake down at the bottom of the shave. All right, 27. What is this one? A nice example.
We have a very cellular lesion here. It looks like a small excision. It's taking up most of the sample. There are some larger vascular channels, but overall it just looks packed.
Yes. And what kind of arrangement would you say from low power here?
Lobular to plexiform almost.
Yeah, that's a good point. I like that plexiform. There are like so many lobules and so interconnected that it almost gives them an interwoven plexiform appearance. That's a great description, Josiah. Good. And then so when we go closer to one of these lobules, we've got the bigger dilated vessels, like you said, and then once it comes into focus here, what's happening in the cellular areas here?
Perfect. Now as it comes in, we can see that these are just innumerable tiny vascular spaces lined by endothelial cells, just jam-packed together, but very monotonous. I'm not seeing a tibia here. I do believe you have shown me one of these recently.
Yes.
And yes, not seen often, but good for an infantile.
Infantile hemangioma. If in the past, when I was in training, I think some people still called them cellular hemangioma of infancy, but infantile hemangioma, I think, is the current name that people like as of the time of making this video. And yeah, like now you see it, right? This looks just like that other one I showed you. Like once you've seen them, they have a very distinct look, but it's also a very scary look if you've not seen one before, because it's like, oh my gosh, there's cells everywhere, right? It's so busy in cellular. The whole dermis, the whole subcutis is like filled with this thing in these big lobules that are filling up all the space. But of interest, of note, look, it like fills all the spaces, but at the same time, we've got pre-existing structures that are left intact, right? It doesn't seem the eccrine ducts and coils and the hair follicles are just hanging out here in between the lobules. It's like the vascular spaces all grew around the normal dermis structures and just puffed up into these lobules like balloons that just filled in all the empty space there, but still have left all of these other structures intact. In fact, in this lobule right here, what do we have in the middle is a lobule of capillaries, and here's an eccrine coil right in the middle, one little branch of it. Isn't that fun? So the problem with these can come when they're in their earliest proliferating phase. They can be so cellular and so closely packed with capillaries that they look solid, and that you look and you just see like a sea of cells inside each lobule. You will have some of these larger dilated vessels, which are basically feeding vessels. They're feeding the blood into the lesion, but it takes some time for these vascular channels to kind of open up, I guess is one of the theories of how this happens. So even these cellular areas here, it's a little hard on this scan, but see this little one here? That's a lumen with 3 endothelial cells around it. So we can see these channels that are a little more open, but even in between, there are other channels that are still not popped open yet, that if we did a CD31 marker, we would see there are actually tons of super, super tiny that are like barely big enough for a red cell to squeeze through yet. Channels all packed in here together. And then there's also some spindle cells, and if you do a 31 with a smooth muscle actin, for example, actin will label many of those cellular stuff in the background that fills in between each capillary, and those are pericytes, the smooth muscle cells that are modified that wrap around all the little vessels that we have in the body, as well as most of the benign vascular lesions that we have that grow. They're usually endothelial layer surrounded by a layer of pericytes. So sometimes if you have a cellular process and you're trying to like visualize what's going on, doing a CD31 or ERG plus an actin can help you to see that there's actually a lot more organization and structure there, and not this diffuse sheet that you thought there was. In this case, we don't need that at all. It's obvious. Also, the other thing you can do is that, these are usually in babies, right? Sometimes, though, they will persist over time and they begin to regress usually, but variable amounts can be left behind as a person gets older. But these are also unique because they're positive. The endothelial cells are positive for GLUT1, whereas pretty much all other vascular lesions, to my knowledge, are negative for GLUT1 in the endothelial cells. So GLUT1 is a glucose transporting molecule. It's positive in the endothelial cells of infantile hemangioma. It's also positive in normal red blood cells. So that's a nice internal control, but that can make it problematic when there's a lot of blood. You have to like stop and look at the actual endothelial cells when you do a GLUT1 stain here to make sure that they are actually staining. Also, GLUT1 will stain perineurium, as you know, and also can stain the keratinocytes in the epidermis, I believe. So in any case, this is a really nice example of infantile hemangioma. And we don't see them removed as often anymore because a lot of times it depends on the treatment preferences, but sometimes they're treated with different medical therapies like beta blockers, things like that sometimes. But I know sometimes plastic surgeons will, or pediatric surgeons will go on and excise them depending on the size and the clinical situation. So I know there's some different thoughts about that. But I think because there are other medical therapies, I feel like we don't see large excisions of big, robust infantile hemangiomas as often, at least in my practice. Maybe pediatric pathologists see this all the time, but I only get to see them every once in a while. So that's a perfect example of one. Perfect.
We have a large muscular artery, just kind of based on the context clues, probably going for temporal arteritis. It's the temporal artery.
Because we know, for anyone who's new watching this, we would never cut a specimen like this otherwise. When they send us a temporal artery biopsy, we cut it up in cross-section and then embed it very carefully so you can see multiple cross-sections in the same slide. And then we hunt diligently for temporal arteritis, and we often do not find it. As Dr. Pitch very nicely pointed out, these are sometimes frustrating and agonizing specimens because they take a long time looking very carefully. But not this one, huh?
No, this one's great. There's kind of like a circumferential rim of lymphocytic, maybe some histiocytes, like an inflammatory infiltrate kind of around and intramurally also. So yeah, this would be great for temporal arteritis.
Yeah, very good. Yes, the muscular artery here, the temporal artery, we can see there's a little bit of elastic lamina here. Much easier to see this on a regular light microscope where you can flip the condenser back and forth to see the refractile lamina, but the lamina is being destroyed by this inflammatory infiltrate that's actually destroying the muscular wall, and the intima has even got a ton of reactive change in here, and there's a lot of lymphocytes and histiocytes, and if we hunt around, we will probably find some giant cells. But in the setting of a patient with, headaches, jaw pain, vision disturbance or loss, where there's a clinical concern for temporal arteritis, and they do a biopsy, and usually they're going to have elevated ESR, erythrocyte sedimentation rate, and C-reactive protein, because there's an inflammatory process. In this context, even if I find a little focal bit of lymphocytes or histiocytes in the wall of the vessel without giant cells, that's very concerning for giant cell arteritis if you see it. And then right here is a giant cell. You may have to hunt around for a while to find a giant cell, but this case is florid, rip-roaring. A lot of times we don't see this because the patients, as soon as they present and there's clinical concern, they give them high-dose corticosteroids, which will wipe out the inflammation. And so when we see it, we may see a big zonal scarring, loss of the elastic lamina and scarring of the muscle wall of the vessel, but we will often not see any inflammation. And I have learned over time that you will often see little tiny foci of disrupted elastic lamina, but when we've sent those cases to eye pathology experts, they've said, yeah, focal loss is not a big deal. What you want to see is either obvious active arteritis like this, or in a treated case, like big zones where the elastic lamina is lost and there's scarring, fibrosis in the wall of the vessel. But when it's obvious like this, no problem. This is giant cell arteritis, temporal arteritis. In other treated settings, I personally find those very nuanced and challenging to interpret in real life, and often a struggle. And for a long time, I didn't really understand why, since the patients had already been treated, what was so important about knowing it. But from talking to some of the treating physicians, they said that the real question is if we think there's no arteritis, then they'll take this patient off of steroids, whereas if the patient has arteritis, they will often leave them on steroids for a longer course. And as we all know, high-dose corticosteroids are powerful drugs that can do great things, but also come with a lot of side effects that can be quite serious sometimes. So that's the significance. But if you have any doubt, find your local friendly ophthalmic pathologist, and they often have a lot of experience in dealing with these. But yeah, this one is a really florid example. And you can even see like fibrinoid necrosis sometimes in the vessel wall. And sometimes I'll see neutrophils with it even. And the giant cells, like we've looked at multiple sections, but only seen a couple of giant cells. And they tend to be, the giant cells and histiocytes tend to be hanging out right there around the edge where the intima meets the muscular media, where the elastic lamina is. So they tend to kind of be wrapping around that. And we usually have to examine multiple deeper sections on these in subtle cases. In this one section has got a slam dunk diagnosis for us.
So zooming in, we see probably a kind of superficial band of small vascular spaces.
Yeah, unfortunately, I can't get it. It's either 45 degrees one way or 45 degrees the other way. It's exactly the wrong angle.
Turn my head and be happy.
Yeah.
So these are small little vascular spaces. Some are a little bit more dilated and ectatic, but overall quite small. Actually thinking a little bit of another case you happened to show me yesterday of a microvenular hemangioma, which I think was even more monomorphically small vessels than we see here. This has a few more dilated capillary spaces, but I think that a microvenular hemangioma is a very rare bird.
Yep.
It's probably the best description for this.
Yes, very rare bird. I like it. And yeah, this is a nice example of one, and they are small little venules, and they, depending on which way you cut them, they can either look like elongated vessels like this, or they can look like little round circles if they're cut in cross sections. So you get a mixture of those. I think the most interesting thing about them, though, is their growth pattern. Now, when we look from low power, this one is kind of like you said, like kind of a band, like almost like a little plaque-like thing. I've seen them go deeper into the dermis as well, but they are distinctly not lobulated, right? They are very trickly, and they intermingle individual channels trickling between individual collagen bundles. So giving it a kind of infiltrative appearance, right? And the appearance is a little bit similar to the vascular channels at the bottom of a targetoid hemosiderotic hemangioma. So I think this entity and targetoid hemosiderotic are both fair to keep in the differential for things that look like this down low. The difference is if I see these channels down here and then at the top see dilated cavernous spaces with hobnailed endothelial cells, then I'd call that a targetoid hemosiderotic. If I just see these tiny little venous channels trickling between collagen, then I'd call that microvenular hemangioma. And you know, we often talk about splitting and why do people split entities in pathology and make all these subtypes. The most important thing is when it matters clinically. This is a totally benign thing. It doesn't matter clinically. I think the main reason is so that we understand as pathologists, this is an unusual pattern that could make you concerned for something else. And historically, I think part of the reason, I was taught this by Omar Sangüesa, who is a great dermpath who has a lot of interest in vascular tumors, that in the early days of the AIDS epidemic, when Kaposiform was recognized in young people, and as a sign of if you were a young person with Kaposis, you probably had AIDS and no one knew what caused it and there was no cure. So it was a hugely important, serious thing that if you called something Kaposis, you're giving someone probably AIDS. You're basically saying that they have AIDS. And back then everyone died, right? I mean, so it was a terrifying time that, you know, I was a young child when those days happened and I was not in medicine yet. But I thought that was a great point that people started to recognize these variants of benign hemangioma that could potentially mimic Kaposisarcoma, and that was important to make the distinction. And so some of these variants, I think, where they started becoming talked about more was for their potential to mimic Kaposisarcoma. Because they kind of, you could confuse this with the slit-like spaces of Kaposi. I think these are actually more well-formed, and you don't get like individual spindle cells trickling out, but you could, you know, you could struggle with an area like that without clinical context, right? So one thing you can do is if you do a CD31 and an actin, you'll see nice well-formed vessels, and each of them are lined by a pericyte layer. But you can also just do an HHVA to make sure it's negative if you're struggling. I do think there is a morphologic difference, and thankfully we live in a day and age where we have immunostains to help us if we're struggling. But in the past, it was much harder. So I think, yeah, like you said, I've only seen a few of these in my whole career. Quite uncommon, but benign and beautiful, and a nice little entity to know about because of its trickly growth. And no atypia whatsoever. These are the blandest endothelial cells you could imagine. Case 30. It's like an Easter egg.
So it looks like there's this kind of pink ball within a lumen with a little bit of a muscular wall, maybe.
Oh, good. I like that you brought that up because that is such a great clue. Sometimes we get something in a space and we don't know, is it a vessel or not? The best way to tell is go look, is there muscle around it, right? Because usually like a venous channel of some sort is going to have some degree of muscle. Now, there are some like thinner walled vessels that have very little muscle, like in malformations. But if you see a nice layer of muscle, then you know you're inside a vessel, right? Good. So yes, it's inside a vessel here, probably a big dilated vein. Okay, and so what is this stuff?
And then it's kind of at the periphery of this pink ball, there's like lines of more acute hemorrhage and then layers of fibrins. The whole pink thing is probably fibrins, and the whole thing is probably a thrombus.
Very good. And I'm sorry I interrupted you, but I really like that you made the point of recognizing the muscle there.
Please.
I also like that you made the point about the blood, that, thrombus can have different stages of evolution within the same thrombus. So the early stage where you're seeing like the blood layered with the fibrin that's depositing, and then you can have other areas that are much more dense fibrin and less blood, and they may or may not begin to have histiocytes and endothelial cells and other inflammatory cells trickling into the middle of them. And this is when the thrombus is starting to undergo organization, right? And technically thrombus is when it's in a vascular channel. If we had this same process, say, in soft tissue without a vascular lining, then that would be a hematoma, right? And sometimes we just get a chunk of fibrin and we can't tell. So then I can say organizing fibrin. And I don't know if it's a thrombus inside a vascular thing, or it's a hematoma, or an old seroma cavity that bled into itself. I don't know, right? Unless I see the context of what's surrounding it, all I can tell you is this is benign organizing fibrin, and I don't know what kind of space it's arising in. So that happens sometimes where this stuff gets shelled out and it's not clear from that. And that's the way I end up signing those out, is organizing fibrin. And if there's really just a ball of fibrin with no tissue around it, I'll say there's no normal tissue. I just have fibrin, and I can't tell if it's in a vascular space or in soft tissue or what. So, and then here there's hemosiderin, and it can get cellular. You'll see some mitoses because these are actively growing endothelial cells. You can begin to see little vascular lumens and the little papillary formation of papillary endothelial hyperplasia. Sometimes you see it, sometimes it doesn't produce it. I don't know why some thrombi do that, others do not. In this case, I don't know if this is in like a vessel that's had some aneurysmal dilation, or if this is actually a vessel that's part of a malformation. I'm not sure, but it's a dilated vein with a large organizing thrombus in the middle. And that's what we've got here. Look at that nice layering of the blood and the fibrin there. Very nice. Now this is case 31.
So we have a punch biopsy. See a little collection of blood right there.
Mm-hmm.
A little bit of clot. Also see little discrete eccrine coils kind of throughout here.
Let's look at the blood first.
So I'm seeing, thinner walled vascular spaces, at least in this larger area. It actually looks more like a lymphatic ectasia.
Yeah, it does, right. It looks a lot like lymphatic, and this is a good example of that phenomenon I was mentioning earlier. See, if you just had this picture right here, you'd say, oh, it's lymphatic, but there's lots of blood in it, and probably if we did a stain, these would stain not lymphatic, because this is probably the blood. The red cells are separating out from the serum, like it happens if you centrifuge blood, It's just happening naturally here since this has been taken out of the body and sitting in formalin for, a day or something maybe, and then processed, so that had time to separate like that a little bit. But yeah, good point. I like that the overlap, it can be pretty striking sometimes. Good. So yeah, dilated cavernous channels here. Maybe some have a little bit of a muscular layer around them. Others are very thin. And there's also some like fibrosis and inflammation, right? And look, like right here, this is good to bring up. See, there's like some increased spindle cells. This is kind of almost like early scar granulation tissue. You can see those kind of changes in vascular lesions in not normal vessels, but in vessels as a reactive phenomenon. This is kind of like akin to like intimal hyperplasia. You can see it in arteries because of hypertension. You could see it in vascular lesions because they either have hemorrhaged or ruptured. See, there's evidence of hemorrhage right there, hemosiderin. And so then you can begin to see this hypercellular zones where you're getting extra endothelial cells and some reactive myofibroblasts. And it can kind of have overlapping features with organizing thrombus sometime. So seeing all that stuff in the middle of a vascular lesion is totally normal and pretty common to see, especially in various malformations that have kind of bled into themselves. Sorry, so back to what you were saying. Yes, these vascular spaces here.
I think there's some other areas where we have some maybe other stuff going on. I'm just looking at these orbs kind of surrounding it. Of the eccrine coils as well, which, don't really have the angiomatous spaces mixed in with them.
Very good. I agree with you, in fact. So this is labeled one way in the answer key, and I think you could make the argument that it might represent an eccrine angiomatous hamartoma, but I personally kind of wonder if it's maybe just a benign vascular malformation, or you could also call this a cavernous hemangioma if you wanted to. I feel like there's kind of overlapping terms. The big cavernous spaces, thin-walled, some with a little muscular lining. It's probably a malformation the person's had since they were born. Usually eccrine angiomatous hamartoma, I find that they're a little hard to diagnose because they are normal things. The question is just, is there enough of both entities intermingle with each other to call it that fancy name? So I've seen a fair number of times where stuff has been labeled that, and I'm like, yeah, maybe. The ones I had seen have a lot of eccrine coils and have vascular channels intermingled with the dermis and the eccrine coils. And here I feel like we're seeing more of a solitary nodule of vascular malformation here that just has some more prominent eccrine coils around it. So you could make the argument that there may be more eccrine coils here than normal, right, for this amount of skin, so that maybe it represents something on the spectrum with eccrine angiomatous hamartoma. But I personally would think probably I would call this just as fun as it would be to give it a fancier name, I'd probably say it's just a benign vascular malformation that happens to have some kind of more prominent eccrine coils around it. I think you could make an argument either way. But I would like to take a moment to point out, though, that this change around eccrine coils is kind of interesting, and I feel like I see this pretty often, particularly in the distal extremities. As you get close to the hands and feet, you often get abundant myxoid change or mucin in the stroma around the eccrine coil, and it kind of splays apart and dilates the space the coil takes up and pushes the coil, each individual tubule, apart from each other. I do not know why this happens. It's so frequent, I feel like, in the distal extremities that I wonder if it is just a normal variation there. I also feel like I see it in settings where there's inflammation or reactive process happening nearby. So I've also come to think that maybe it is more abundant, this stuff happens in the setting of reactive processes, but I do not have a good answer for you. If you're watching this online and you know some great literature about this, I'd love to have a link posted down below to that article. Because I've observed this a lot over the years, and I feel like people see it, and if they've not noticed it before, they're like, whoa, what is going on with the eccrine coil? But once you know that this can happen, you'll start looking and you'll encounter this. I think I see it a little more often maybe in soft tissue cases where they're going way down deep, like taking something from the synovium of the ankle, and they happen to get some skin, and they've got some bursitis or something on the foot, things like that. And then I see, these big, myxoidy expanded eccrine coils in the background. So I feel like maybe I encounter it more than other people in Dermpath because I also do soft tissue and see these larger, deeper excision specimens that we don't see as often in Dermpath. So just so you know that's a weird phenomenon that I don't know that it means anything. Also, I would point out, this is a faded slide, so you can't tell, but on a new H&E, this is almost certainly myxoid, blue mucin myxoid, hyaluronic acid. And around eccrine coils, I ignore blue mucin or myxoid material. I do not use that as evidence of connective tissue disease like lupus. I find that it is normal to have a variable amount of myxoid material around here, just like you see it in the lining of a nerve inside the perineurium. In those settings, I totally ignore it, and I don't use that as a useful clue to diagnose lupus at all. I will only use, having the right inflammatory pattern, and also interstitial mucin. That's where I'm looking. But I think this comes up sometimes, and so in my book, I just ignore any mucin around the eccrine coil as not being helpful to be a point towards connective tissue disease. Obviously not related to this context of this case here, but I just thought it was a good time to bring it up while I was thinking of it. And since I've been verbose on, every other single case this morning for the past 3 hours, why not on the last one? And with that, thank you very much, fellows, for sticking around to the bitter end. And if you're online and you've watched all 3 hours of this, you are now a master of vascular tumor pathology. Well, I don't know if we ever master it fully, but you've certainly gone a long way towards getting a head start because these tumors are challenging. And thanks very much for watching, and fellows, have a great weekend.
That was like fellow remediation session. That was fantastic. I don't know
Thank
how you
you.
talked for that long.
I don't know either. I'm almost out of voice, and I'm going to leave your comment in, so it makes me look good to my people online, and to know that the fellows don't hate me for going for 3 hours. So thank you very much for that.
Never.
All right, guys. I appreciate it. Have a good one.
All right. See ya.